We're live in 5, 4, 3, 2, 1.
Okay, you can see my opening slide, Supriya.
Yes.
Let me just minimize this. Just give me a minute. So the slide is running through, Supriya?
Yes, it is.
Sir.
Okay, great. Okay, I'll start. Respected faculty, dear colleagues, dear doctors and friends. So I welcome you all to this fourth Meet the Masters course from SARATHI Specialty Orthopaedic Center, Bangalore, India, along with Geriatric Orthopaedic Association of India. Today's faculty are Mr. Evert Smith, Mr. Mehool Acharya, and myself will be talking in the end. So at the outset, I would like to say that the Geriatric Orthopaedic Association of India welcomes you all to the SSOC's fourth Meet the Masters course. I thank all the faculties who have spared their valuable time to educate us today. I thank Professor John Eboniser, President of Geriatric Orthopaedic Association of India, and Dr. S.S. Amarnath, Secretary of Geriatric Orthopaedic Society of India, for associating with SSOC and getting CME credit points from KMC for this meet. The KMC has given 1 point for this meet via GOAI. Special thanks to Dr. Ashok Sham, my good friend, for bringing this through Ortho TV through the whole of India. And also thanks to Mr. David Penford from Clockwood Medical UK for doing the same in UK. I thank all the sponsors who are standing shoulder to shoulder with my center in these difficult times, particularly Jason and Shashi. I thank all the delegates who have spared their valuable time and for being part of this unique, thought-provoking webinar. The program details, we are going to kickstart, after the welcome with the introduction of faculties and the chairpersons, and Professor Ebnezar and Dr. Amarnath are the chairpersons and moderators for this evening. So after introduction, there will be a verbal introduction of GOAI, and about SSOC I'll introduce in my last presentation. And there is will be a brief talk from Professor John Eboniser and Dr. Amarnath. Then we'll kick on with the much anticipated talk, robotics and beyond robotics hip surgery. Much awaited talk really in India. And Mr. Evert Smith is going to talk about it. He's an honorary senior lecturer in Bath University, the course director of the world famous Bristol Arthroplasty course. He's a consultant in Spire Hospital, Bristol, and Lister Hospital, London. Then we'll take some question and answers. This will be followed by a history of Bristol hip arthroplasty course, creating and passing on a legacy to the hip surgeons across the world. So Dr. Evert Smith is going to present a few slides, and there's a video on my side which I'm going to play. This will be followed by the Bristol hip arthroplasty course is happening in just a few weeks' time, in 3 to 4 weeks' time. So there will be a presentation on BHAC 2021, the academic fees, program at a glimpse. Then Mr. Evert Smith will invite all the Indian delegates, to participate in this fantastic meeting between 8 and 8. So then we'll move on to a new segment I started called Creative Corner. We had it last year as well in this meeting, and we're just going to analyze what's happening, what is the pandemic doing to the world really. This will be followed by an amazing talk, second most important talk of this evening, decoding soft tissue algorithm to achieve a forgotten knee after total knee arthroplasty in 2021. Much awaited talk really, and a lot of people in India are excited about this talk. This will be done by Professor Mehool Acharya from Evert Orthopaedic Center, Bristol, followed by question and answers. And at around 9 p.m., I will start with the last didactic lecture of today, which is complex knee and hip surgery in India in the light of Consumer Protection Act, CPA 2019, which is a law in India right now. So this will be followed by a real-life surgery from 9:30 to 10 p.m. or till the surgery lasts about robotic TKR, the botway. This is completely new concept in India, and Mr. Mehool Acharya will take us through the steps of this robotic TKR, the botway. This will be followed by question and answers for the whole program, and a vote of thanks from Dr. Amarnath, and we will close the meeting. So going to introduction, Mr. Evert J. Smith doesn't need any introduction in India. He is a consultant orthopedic surgeon at Spire Hospital, Bristol, and Lister Hospital, London. He was a former UK representative of the European Hip Society. He's a designer surgeon of the Biomet Exceed ABT system with 15 degrees phase changing acetabular cup. So a brilliant innovation really, and very helpful in dysplastic hips. He's a program director of the world famous Bristol Hip Arthroplasty course. He's a fellow of Professor Bill Harris, and Professor Heinz Wagner. And these two surgeons don't need any introduction in the orthopedic world really. He's a member of the ODEP and Beyond Compliance in the UK. He was regional coordinator for NJR from 2003 to 2016. He's the international editor of Reconstructive Review Journal and HIP International. He's an affiliated staff member at the University of Bath Center for Orthopedic Biomechanics, contributor and member of the advisory group Donaldson Arthritis Research Foundation Center. He's an advisor to British Hip Society concerning problems and negligence cases. He also runs an amazing charity, Arthritis for Hip, along with his amazing wife, Daniela. Coming to our second speaker, Professor Mehool Acharya. He's honorary professor at Orthopaedics at Wales in Untitled University. He became a professor in 2021. Many congratulations to Mr. Evert for becoming a professor. He's a dynamic orthopedic consultant from North Bristol NHS Trust, one of the busiest major trauma center in the UK for nearly 11 years now. He specializes in pelvic acetabular reconstruction, complex trauma of the hip and knee reconstruction. He did his fellowship in complex and revision orthoplasty from Australia. He's a good teacher and won prestigious Trainer of the Year award in 2014. He's a deputy lead for skills and simulation in Severn region. He is a faculty in the prestigious maternal and AO pelvic master courses in the UK. He's a co-convener of Bristol Hip Arthroplasty course, along with Evert and Mr. Tony Ward, who was my trainer as well. He's going to talk about the future, the soft tissue algorithm to reach a forgotten knee after total knee replacement in 2021. So our next speaker in India doesn't need, our moderator doesn't need any introduction. Professor Dr. John Eboniser, he was my teacher as well. If I had to really go through Professor Ebnezar's CV, it will take 2 days for me. So I'm just going to focus on the key things in the red really. He is a recipient of 2 times National Award, the Padma Shri Award, and he's been awarded Dr. B.C. Rai Award, which is the highest award given to any doctor in India. So it's an incredible achievement. He is MCA Silver Jubilee Research Award he has got. For this state, Karnataka has got 2 top state awards, Rajyotsav Award and Kempegowda Award. He is a holder of 8 Guinness World Records. He's the author of around more than 200 books in orthopedics. He's a faculty in many, many international courses and over 70 scientific publications. He has pioneered holistic orthopedics. He's a TED speaker and a motivational speaker. And he was a former vice president of prestigious Indian Orthopedic Association as well. So I think most importantly for me, Dr. Ebnezar sir is an amazing human being. During both the waves of coronavirus, despite what he is really, he stood in the railway stations in Bangalore and helped the dean to do RT-PCR and check the spread of virus. So it is incredible human being. I don't not seen any orthopedic surgeon doing such a work really at his high exalted stage. So that's why he's getting all these awards, because he's an amazing human being. Last but not least.
Thank you, Srikanth.
Thanks, sir. You're welcome, sir. Last but not the least is Dr. Amarnath, my good friend. So he's a director of Geriatric Orthopedic Association of India, secretary of GOSI and ATOMS, which is Academy of Advanced Trauma and Orthopedic Master Surgeons. So I think this is where I will stop, and I think the podium is now to Evert actually. I'll try to stop sharing this, and then we will hand over the podium to Dr. Evert Smith to start his first presentation. Supriya, can you stop share from my side? Just try it.
Shri, are you going to get John to speak?
Sorry. So I just missed that. So I think we'll get John and Amar to speak.
Good evening, everyone.
Before Evert gets to be warmed up.
Yeah, sure. Before Evert warms up. Sure.
Well, good evening, everyone. It is been a very exciting day for me today, because this is a great academic collaboration with our own Srikanth. I have seen him grow right in front of my eyes from Bangalore Medical College when he was doing his undergraduate course. So when I was there in that college, from then on to now, he has grown tremendously. And the quality of his academic meetings is amazing. A single man doing such outstanding work. So it is a privilege for us to be associated with him, GOSI, as a GOSI organization. He's our core member of Geriatric Orthopaedic Society of India. We felt that if he associates with his organization, then he can make a wider impact and reach greater audience. So now that we have got the accreditation also coming from Karnataka Medical Council, so this will add it's a win-win situation for him and for us too. So I should thank Amarnath for all the labor he puts into getting this medical council registration, which is not that easy in Karnataka. It is very difficult job. He does it. He's an efficient man, and he organizes things very well. He takes the load off my head so much that I can breathe and can relax. And because of him, we are able to do a lot of programs like this. So all the best, Srikanth. You have lined up a very good program. Robotic surgeries and ligament, what to say, your forgotten knee technique and some creative corners. So many things run in your brain. I'm wondering how it works. You come out with such innovative things, and you come out to make it very interesting. So I learn from you. You say you are my teacher, and you are my teacher too. I learned a lot of things from you.
Thank you.
So good luck to you.
Yeah.
And I'm sure that this will benefit all the young and senior orthopedic surgeons and postgraduate students too. Good luck to you. And hope we'll have many more collaborations like this. And we are with you always in your academic, what is the spread of, this knowledge, which is a great service to mankind. Thank you so much. Thanks for the nice words you spoke about me. And, I'm indeed happy. Thank you so much.
Thank you, sir. Thank you for your kind words. And I should really thank all my trainers, including you, for me being in this place. I think I hand over all my achievements because of you people, Evert, Mez, you, and Amar, all of you. Really. Thank you. Amar, do you want to say anything?
Thank you. All the best.
I think just a brief, nothing much. I think most of you know about it, but for the newcomers and the new delegates who are logged in, a brief about GOAI and GOSI. Geriatric Orthopaedic Association is a registered body in India. It's a national body, as well as Geriatric Orthopaedic Society of India as well. We have close to 1,000 members now. We are just 7 years old and stepping on to our 8th year now. And we've had a fantastic journey, and it's been very rewarding in terms of the academic and learning from each other to make things better for the humankind in terms of surgical, non-surgical, be it which direction we go ahead and take it forward. Orthogeriatrics is a well-known field in UK and in all the developed world. And in India, John and I started this organization keeping in mind the geriatric orthopedic challenges that each one of us are going through are humongous. And we need to get a focused group and the kind of expertise that we can leverage on from each other's knowledge and then take it forward to share it for the betterment of our patients. That's one of the biggest key factor. And today, with that in mind, we have grown to about 8 to 9 Southeast Asian countries, and then we are going ahead to spread our wings. And the thought process, probably as Evert Smith was talking to us in the evening with regard to Africa, South Africa, and Botswana, and probably beyond. So we will keep you posted. And there are a lot of research work that we are going to be planning in the year to come, 2022. We'll all focus on that. And then definitely I would encourage, if you are not a member of GOSI, that is Geriatric Orthopaedic Society of India, I would encourage. And one last sentence, probably, we have an annual conference coming up this year as well. We are going to be going on virtual. It's going to be in the second week of December. We'll keep you posted on the details. Sri, all the best for your endeavor in the academic programs that we are going to be lining up. And definitely, we will take it forward into, making it much better win-win in terms of academic for the doctors across the globe. All the best.
Thank you. Thanks, Amar. Thanks for this. And, you've been the silent backbone of GOSI, and the amount of work you do on the background is incredible, really. So heartfelt thanks for you. And our friendship goes back to a long time, around 30 years since once I met in Macclesfield in Manchester first time. So, and it's gone from strength to strength. So I think, so I think we'll kickstart with the first presentation of today from Mr. Evert Smith, the much anticipated presentation from Mr. Smith. So if Mr. Smith can kindly share his screen, please.
Is it on?
I can see you, Evert. I can see you. You just have to first presentation on your laptop. Then you can share. Yeah.
Is it there?
Just give me a second. We can see you clearly.
No, not yet.
Okay, so let me try again.
Yeah, there you go. Starting.
Here you go. You're on.
Robotics and beyond. So yeah.
Fantastic.
Brilliant. We can see the first one. Robotics and beyond.
Can you hear me?
Yeah, you're loud and clear. Thank you.
Good. Okay. You mean, can you hear the South African accent?
Fantastic. Wish you were today.
Okay. I mean, a lot has been said by Sri and also his friends who've become my friends. And I think both Mez and I would support everything they've said about Sri. He's done exceptional work and developed remarkably in this area. And he knows that he can't do this sort of work without these supporters. And he's already mentioned in one of his slides that both Tony Ward, who's been around before Mez arrived, and Mez himself are people that I can rely on and trust at any time in Bristol. And the same, of course, goes for John and Amar and Ashok, who support Sri in all these things. I must thank both John and Amar for the work that you do in GOSI and your ability to develop these registrations and accreditations. Quite marvelous. And Ashok, you're always putting a platform ready for us, which is immaculate and perfect. So thank you for that as well. So just some words to the people who've all created and developed together. So I'm going to talk on robotics and beyond robotics. I'm going to be a little bit humorous and glib about beyond robotics because I'm an avid movie fan and I let my imagination run riot. So don't take any of this, the tongue-in-cheek stuff too seriously. I won't mention the sport because Sri already said South Africa is playing England. So I put that on hold and tape because I'm too nervous to watch it. But I hope India gets through to the next stage and goes onward and upwards. Right. How do I move the slides on, Sri?
First on the presentation, and then then you can move it. Yeah.
Click on that.
That's it. That's it. Right. So I've got to provide you with my disclosure as always, and it has to do with what Sri mentioned, which is the Arthroplasty for Arthritis charity, which brings in work and aids us in our research. I've always consulted and done work for Stryker, and that links me to Mako. So I really don't know much about the other robotics except for to go around the tables in America to see them. But that's my links, and those are my biases. I think getting to know Amar and establishing a rapid and quick friendship, we had some great fun in the sociological aspects of life. And I don't think this necessarily portrays itself in countries where there are large numbers of people who struggle. But in essence, the Western world has shifted into this risk society, which was coined a long time ago by three gentlemen in 1980. And I think I can see this in comparison with the way that I grew up and my children grew up in Bristol. And it is true that risk aversion is a factor in everyday aspect of daily life. And if you go into the private hospitals, both in London and Bristol, it is peppered with panic with every move that you would make consciously as a doctor, trying to support and do the best for this patient in your care. And sometimes it actually runs across wires to what you are doing, because all they're worried about is getting into trouble from the risk you may take. And one of my very, very honorable colleagues who you guys know, who's a professor in London, said, we're getting to the point now that they don't really want us to operate. And this is a worry, of course. And this is why I'm talking about this, is because they're in fact loving robotics, because they're hoping they won't have to put in some never event for the robot, because the robot will always do it correctly. And that's a great leap of faith. So we are a society where we use creation, distribution, and manipulation of information that has significant economic, political, and cultural impact. And you can't shift that away and out of the theme of robotics and where we're going with all of this. You have to keep in mind how this was driven. Now, the challenge to the medical profession, and again, I turn to a great number of discussions over meals with Amar, where we know that the internet has changed the balance of knowledge between healthcare professionals and the public. And in fact, Amar used to take my mobile telephone away from me and show me how to use it. So it shows how far Africanized I was. But the truth of the matter is that there has been a shift, not only from our risk aversion, but there has been a big shift from the patients in the Western Hemisphere and educated people about what they're demanding. And the public availability for specialized knowledge is now at your fingertips. And the access information on alternative healthcare approaches nearly can drive you crazy, because everybody will have a view how the new Reiki yoga actually restores cartilage in your hip joint. And this has been shown in the new center in Birmingham. And you either have to keep your mouth shut or take a sip of coffee, because you don't know where you are when the patients come at you like this. There is healthcare performance statistics, and this is loved by the non-operators. The non-operators love performance statistics. You can always be confident when you're the professor in Bristol and you don't operate to tell all the operators in Bristol how badly they're doing. And clearly somebody like me, who has utilized masses of that tragic metal on metal era that we went through, my performance went from somewhere right at the top in the NJR statistics and plummeted straight down as I groveled through all the revisions that were created from 2011 onwards. And of course, then there's consumer rights. And at the bottom of the slides, the patients have become more involved in healthcare decision-making. And that takes us to the next slide, confused.com. On Monday morning, they told us that on this ASMO robot, which is now being debunked by China, I've researched the subject and I want robotic assisted hip or knee, and we're concentrating on hip today. And I know you can do the operation without anesthetic, and that the next day you can go and play tennis. I want my hip knee surgery to be done through a tiny cut. And they usually show it to you with your fingers, which is really about 2 centimeters. Well, robotics. Again, I said I'm a mad movie buff, and I must turn you to Blade Runner 2049, which was in 2017. The graphics and the effects of this movie are quite staggering, quite staggering. And the first robotic assisted THA was as far back as 1992. There is a haptic or semi-active system which allows the surgeon to operate the robot arm manually whilst constraining the system, and I'll go back to that. And then there's the automatic one, which is what the patients dream of, because you're just going in and you're just going to core a little hole, stand back, and the robot's going to do all the rest. This performs the operation autonomously based on your preoperative planning. Now, Nexus 9 replicant is in fact where we're going. And the lady in the picture at the bottom right, she is not a human, but a robot. And she is so close to us. This is the challenge, and this is the excitement that faces the conglomerates and whatever you want to call the people who run healthcare from a power base are looking towards, because they are risk averse. They are risk averse, and they also don't want to spend money. Right, well, we know about this because we are all into our orthopedics. A fully active robot autonomously executes the planned bone resection and implant position. And those are the ones that are a concern. And the surgeon oversees the operation as for the RoboDoc. Now, the RoboDoc actually, when I looked up during the week, has had a number of lawsuits against it. I'll leave it at that. But the semi-active robot enables the surgeon to control the resection, implant positioning, and it has that intraoperative feedback to limit the deviation from the preoperative surgical planning. That's the maker. Now, I've been not only on the Stryker course, but I've actually been involved in the teaching on the Stryker course, and I've done robotics. And then unfortunately, my private hospitals, both here and in London, removed the robot. So there's navigation, which is important, and that has rocketed on. The computer system does not actively control or restrain the motor function of the operating surgeon. There are fantastic smartphone apps that aid good results for superior positioning. And now we're into imageless and CT-based navigation to develop greater accuracy with the aim of the reduced clutter in theater, the radiation, but it is very, very costly. So the robots and the orthopedic conglomerates are all having a go at this. And this is the list. I know the gentleman that runs the Mako system worldwide, and he tells me that he is now selling, some of you may know him, Nick Margree, he is selling more robots than he ever did in his life before. Everyone is clamoring for robots. I'm not sure whether that's true, but certainly they're making a lot more money now. The evolution of robots. It requires a learning curve. It requires an adjustment to how you do your surgeries. And I was invited to Indianapolis just before lockdown, where I operated for 3 days with a good friend of mine. And I noticed that he, as the senior surgeon, who was a highly skilled surgeon, could simply carry on with the robotic surgery and adjust accordingly based on his experience. And then when I watched the fellows in the afternoon, I saw that the majority of the fellows didn't even look at the wound. We opened the wound, and the fellows were then all crowded around the robot, arguing about what should or shouldn't have been done, and hardly looked within the patient. And that sort of concerned me a little bit. But anyway, the FDA approved robotic surgery in 2000. The fault, I think, has been the implication as a marketing tool before, and driven up the high costs of these robots and made it quite difficult to justify in countries where healthcare is not even. The other big problem, and we'll return to this, is the high success rate of a conventional total hip replacement in any way, in any event. We know that it's now routinely used in general cardiothoracic surgery, gynecology, and urology. In Bristol, this is done every day, and their robotic systems work very well. And I've had lots and lots of patients who've had gallbladder surgeries with robots and have been highly satisfied. So it is coming. Right, I bring directional reaming because Sri actually asked me to sort of make a case for perhaps not necessarily using robots. And as I developed as a surgeon and all the different places that I went and learned from some wonderful people, and he did mention Heinz Wagner, and I will add that I'm not too sure there are many people in the world that can operate like Heinz Wagner. So that was something that absolutely staggered me. But I think there is a trick in terms of the acetabulum, and I'm not missing out the positioning of the patient, which I think is absolute key to the problem when you're doing a lateral decubitus position. That's got to be key, and maybe we even need to find clever chips and clever ways to actually confirm the position of the patient and halfway through the operation as well. But the thing is to start with a reamer, identify the walls and the rims, and then ream at 40 to 45, not drive down hard at 90 degrees as in the old days when you used cemented cups, and identify your anteversion and inferior edge which sits inside the towel as you are reaming up to the size that you're going to put your cup in at. And as you are doing this, you get a perception of the anterior and posterior wall. And it may be even better if you feel this wall to gain an extra perception of where your cup should be. You then deepen to the true fall so that by the final ream, you have your perfect anteversion and inclination set into the position of your hand holding reamer that you're using. And you're doing that over and over, replicating it, and then you repeat it when you put in the cup. It's no good just smashing directly down at 90 degrees, having a ream upward, and then trying to find a position. And in this way, you tactically and visually position your cup on the way to its final position. You then trial the cup, remove the osteophytes, and put in the definitive cup. And this is something that we've really developed with our minimal invasive surgery in Belgium. I was really taught this art by De Beer, who was absolutely fantastic at this. And it's a trick to those people who, like me, don't have the advantage of having a robot. Now, the increased inclination and anteversion is our worry, and the increased wear of all bearing surfaces occurs with inclination, not so much with anteversion. The range of movement is reduced with abnormal cup position, and there's a 7 times higher dislocation when the cup and stem is anteverted beyond 40 degrees. And this is a problem when you get nervous when you start. You have to keep that nervousness out of it and not dial the cup away from you so much so because you do not want to get that anteversion. You set up your own impingement and your dislocation by doing this. And of course, retroversion of the cup causes iliopsoas tendinitis. Inclination angle often is increased in shallow sockets because you chase the superior wall. And that's why the reaming that I've described is important, because you aim at getting your hand position around about 45 and then maybe close it a little further. You can use the face-changing designs that I developed in CDH, and I'll go a bit onto the robotics in this cup a little later, which I found wonderful. And we now know that freehand placement accuracy is only at about 40 to 70% of the time, even in experienced surgeons, and the chance of placement of within 5 degrees of your intended position is around 20%. So we know it's low. I just wanted to go into stance and posture quickly, but simply to say that the effect of the pelvis tilt on cup orientation is predicted by the stiffness of the pelvis. And you can see in these pictures of stiff, normal, and hypermobile how the cup changes. And the one that you only have to worry about in hip surgery is the hypermobile female, to make it simple. That's the one that you have to worry about. And I've already mentioned the lateral decubitus position. I think it is very important not to put the posterior pad right in the middle of the lordosis, because you will increase the lordosis on the table no end. You have to find that top of that sacrum and park your wedge against that sacrum just to not exacerbate the hypermobility of the back. So you have to adjust this person's performance with their spinopelvic axis to your cup position. And this is different from that old-fashioned way of going to Levennick's zone, which was, by the way, an absolute rubbish paper. Stance and posture. So cup placement at surgery does not translate to cup position when the patient stands or sits. The influence of pelvic tilts becomes clinically relevant when cup inclination exceeds 50 and anteversion exceeds 25, particularly in the hypermobile pelvis. The cup in a hypermobile pelvis should be positioned in less inclination and anteversion. Robotic THA does not use dynamic preoperative imaging to assess the relationship of the pelvis and the spine during functional activities. Beware, beware, beware. These are some of the papers that they throw at you, and there are many of them. And of course, during the last week, I've boned up on all my stuff because Sri sort of threw the curve ball at me, the googly, about coming to talk. Right. I think garnishing all these papers and gobbling them up in the last week, there is no doubt that robotics and navigation prove the accuracy and the precision in spine surgery, for absolute sure. No doubt about that. There's improved accuracy of joint position and screw placement, no doubt about that. There are great variations and discussions in how this affects the length of stay. But I might add, if you use a robot and you chew up all the muscle and you have a wide wound, you probably don't reduce the hospital stay. There's a question mark about infection rates. There's a question mark about reduced pain and scarring, and I'll talk a bit more about that. And of course, there's a question mark about reduced radiation exposure, and I think that's more for spines than anything. The disadvantages are the learning curves, and the learning curves are a problem. The costs are a big issue. The insertion costs are massive. And of course, the companies love this. So we're hoping, as I actually discussed with all of you, including John and Amar, that we're hoping for the next generation of robots to hit South Africa and hit India, where you actually don't have to pay 1.2 million just to park a robot in your hospital. I mean, it's quite ridiculous. Increased radiation exposure, that's the opposite view. Increased surgical time, probably. Does it protect soft tissue and ligaments, particularly with MIS? Absolutely not convinced at all. There is a higher rate of ossification, heterotopic ossification. And that being the case, my thoughts are most definitely that it damages soft tissue. I don't know how some of the publications can suggest the alternative. If you're seeing higher heterotopic ossification, you are definitely swathing your swashbuckle knife through the wound and grappling onto it and shredding it and causing problems where you shouldn't. Does it reduce pain and improve patient satisfaction after 6 months? Nobody really knows. There's been no RCTs on this. There's been no hard evidence of this. Potentially enhancing implant survival and long-term outcome. This is the final comment in all the papers that they suggest. Now that their hip is in a fantastic position, it will indeed improve the survival, but we, of course, do not know that yet. No difference. There's really no difference if you do a functional score at a year. If you look at leg length discrepancy, we can't see in the short space that robots have been full tilt that the rate of revision has reduced in that short period of time, and the relevant amount of blood loss is unclear. Leg length discrepancies vary. There are studies reported leg length in patients who underwent robotic assisted and conventional THA. I could pull out 2 studies which showed that leg lengths did not differ significantly. And if you look through the papers, the rates of the difference, more than 10 millimeters measured, there was really no significant difference between a robot and a conventional THA. But never forget the papers, particularly those from, Beverland and even George Langhammer in this town, that clearly showed that the grading of surgeons made a difference to leg length discrepancy. So if you've done a number of thousands of hip replacements, your leg lengths are more likely to be equal as compared with my first total hip replacement in Cape Town, where I looked as though I had 1 peg and 1 short peg. Right, cup position and placement. If you assess this, and we're just going to call it the ideal cup placement rather than these wonderful zones that Levinek talked about, it was definitely better with robotic THA compared with conventional hip placement. But again, I don't think that the surgeons had concentrated enough on that sequence of events that you should go through in positioning your cup when you're in surgery. The rate of stem alignment of outliers is significantly lower with robotic groups. So there's no crazy first case that I had in Cape Town when you're using robotics. It doesn't allow you to shift out so much. The rate of ossification was significantly higher with robotic-assisted THAs as compared with conventional. And heterotopic ossification can reduce hip range of motion, not always. And I give you two pictures. The one in the left hip on the right slide shows a significant HO, and they certainly were stiff. And so was the one with the circle on the other picture. The dislocation rate was slightly higher following robotic-assisted surgery. And this made my brain scramble a bit because we've just been told how accurately they position the implants. But I suggest to you that it is probably because they're missing the trick of the spinopelvic axis. And in fact, more interestingly enough, because of muscle damage, the Trendelenburg rate was a positive rate was significantly higher in robotics as well. If you trawl through the papers, there are intraoperative fractures, there are issues with infection, nerve palsies, DVTs, thigh pain. But in general, when I amassed my screening of all these papers, I felt that there were fewer complications with a robot, but for heterotopic ossification as compared with conventional approach. I looked up more robotic data. And because I'm in ODEP, I look up more robotic data every 6 months. And funnily enough, the more robotic data hasn't changed in the last year, but they do relate to 144 deaths directly due to robotics, over 1,000 injuries, 8,000 device malfunctioning robots in the United States in the last few years, burnt or broken pieces of instruments, electrical arcing, having to interrupt surgery to restart a system. And you may all know of the cardiac case in Scotland where the robot started spinning round and round and round, and nobody could control the robot because nobody had the space gun to shoot the robot in this Nexus 9, and unfortunately the patient died on the table. DDH is a passion of mine, probably from my own problems with my daughter, and it involves the heavy pelvis, which is smaller on that side as compared with the contralateral side. The strongest and most viable bone sits in that original socket, and you have to find that true flaw. The transverse ligament in the inferior border of the true acetabulum is the real key landmark. This shows a Crow 3 as I do it because I don't like complex classifications. Right, the surgical plan. Let's just say Amar and I are going to surgery. The surgical plan is key, and depending on what we've got, the preoperative pelvic radiographs we can use, we can go on and use 3D CT scanning, and if we're lucky, and this is where I really think it's made a difference to me when I've gone overseas, is the robot. Posterior approach, sciatic nerves evaluated, protected, and you do a proper soft tissue release, not minimal approach surgery for this type of surgery. And you can see the types of true acetabulum from a simple Crow 1 to a high elevated Crow 4 on the other side. And if you look at the robotics in DDH, there is validation that the robotic use achieved acetabular position. And it's so good to go overseas to Belgium or to Holland and have the setup where you're pretty well sure, because I'm experienced, this is where I was going to put it anyway, and the robot puts it there for you. It's absolutely wonderful. And if you look at Hayashi's most recent paper in the multivariate analysis, revealed that a posterior pelvic tilt odds ratio 1:1, 95 confidence interval shown to you, and anterior surgical approach, those two things were predictive factors for inaccurate cup positioning of robot-assisted THR. So there you are. You have this robot and you have this machine that really helps you. But if you don't put your patient in the right position, or you do an anterior approach that you're not skilled with, you don't end up doing very well. So again, there's this moot point in debate about robots. I think you have to get the whole pathway correct. From the time that patient comes on, you miss a subset or step in your robotics, you don't end up doing well. We've hinted at it already. High volume versus low volume. I'm not too mad on this. I think there are skilled surgeons who can do 20 hip operations a year and probably do them better than me. So I don't think it's so much volume. I think it's that experience and that observation of developing your knowledge within your skill base or speciality. And if one chap has done 500 and you've done 100, don't worry. Practice at the things that make the difference in your operation, and it won't matter. But again, it's the people that drive orthopedics that want to exclude a good surgeon who does 50 hips a year as compared with somebody that does 200 hips poorly. And I think that is just complete nonsense. So low volume surgeons, taking into account what I've said, those people who are not perceptive have a twofold increase in malpositioning. Difference in cup position in terms noted between the surgical consultants and residents. And that's George Lankhammer's paper from here, that there was a vast difference. The significant difference between the intended angle and the actual angle for inclination, but not for antiversions, not for antiversion consultants compared with residents. So, not so much. Problems with obese patients. In fact, this is definitely my problem. Excess tissue creates difficulty locating anatomical landmarks. I don't think it's all that, and I've referenced the papers. I think it's the walk in an approach to hip in patients who have obesity. And now in America, as you know, the super obese classification is a BMI over 50. A BMI of over 50 is over 220% of the normal weight of Amar, John, Shri, Mez, myself sitting here, 220% more than we weigh. That's 2.5 times Evert that you've got to operate on. That's bad enough. And when I go into these patients and I go into the hip, I actually think I'm crazy. Last year at the Spire Hospital, we had to get in a special bed with a special width control for a man who weighed 150.6 kilograms. When I went into his hip, I promise you, when my finger was reaching the acetabulum, my elbow was inside his body. And I thought, I'm not too sure whether I want to operate on people like this anymore. And maybe that's because I'm getting old. My conclusion is that radiographs, sadly, are inaccurate due to poor beam center location, magnification, and position of the pelvis. And Shri will remember how frustrated I used to get when the radiographer could not center on the symphysis pubis and give us both hips on an AP pelvis at Southmead Hospital. It used to drive me bonkers. If somebody cannot do simple work and actually garnish the right position for your postoperative hip x-ray, how are you to measure something on an x-ray that is wrong right from the start? It's just impossible. And I know we all do it, and I template still religiously, but I have that horrible feeling that I'm probably doing it for naught. Robotics can provide accurate component placement, and I think this is where we're shifting. The adoption has to be limited, and it is limited because of finance due to the increased time of use, complexity, and cost. The reason why Spire got rid of the robots was because they couldn't push through the cases and gain the money by the end of each list. And beyond, a little bit tongue-in-cheek, but I have exciting friends in the area of engineering who I'll mention later, and he talks to me about this. He doesn't know anything about socioeconomics or people or patients, but he's obsessed with this sort of thing. So I think we are into the advance of the composite material. We have plastics that can go on a rocket, that can come down into the earth, and the plastics don't even burn or change. Instrumentation is poor. Instrumentation can be vastly improved. There is no doubt about it. I've seen the next generation of some instrumentation used in New York State Hospital, which was sent to me via Stryker, and I thought it was quite remarkable. Precision preoperative planning linked to 3D printing and bespoke hip arthroplasty devices for single patients are definitely on its way. Robotic devices And I'm excited now because I'm going to have a robot assistant, Nexus 11, of my choice and dress to assist me in the next few years that I work. And of course, there's the microchip. And this goes back to my friends in India who always seem to be far ahead of us in IT. The microchip in the patient will control the healthcare, which will be self-regulated. And the patient will know when they're coming for a hip replacement in the next 50 years. It'll all be prepared for us. And probably we'll be able to get them bariatric surgery in Bristol so that they shrink down to a normal size so that we can operate properly. Post-operative hemostasis management will be done by things like drones and robots. Unfortunately, healthcare control of patient data will come. There is no doubt. Our very, I think they were called the 1970 people who wanted a free and happy life and don't believe in any data being passed on are in for a big shock. And beyond again, well, there's coherent electron displacement for quantum information processing using attosecond single cycle pulses. I mean, this is fantastic. This is going to be day-to-day stuff. Drone usage I've mentioned. This is going to be used every day. And then the last thing for my friends in India is that when I come and visit them in 10 or 15 years' time, they're going to be introducing me to some of their friends who are going to be robo-sapiens. An alteration of humans and robots. I'd like to say thank you from Bristol. And it's been wonderful meeting with you all at this meeting.
Thank you, Evert, for an absolutely jaw-dropping presentation. So I'm completely bowled over, really. So I just invite the participants, if they have any questions, they can ask, who are in this group, actually. So if not, then we'll take questions. If there's anything on the Ortho TV, Dr. Ashok can tell us if there are any questions from those who are watching it. So I'll probably kick off the first question, actually, for Evert from myself. Evert, you mentioned that when you looked at the data, the 144 patients were sort of killed by the robot. Could you find out exactly what was the reason? How did it happen? What was the reason for the death?
No, they do not say that at all. They will not give out that information. And I'm surprised myself that over the last year, Maud hasn't done more about inviting the details of that and showing that and sharing with people around. You'd have to use your imagination. But again, my suspicion is they don't want to go there. And when the FDA doesn't want to go there, they just put the numbers out and nobody tells us. The only real specific case that caught my eye was the one in Scotland where the robot arm and the thing slung around so that everybody had to move away from the table. I think it was, the control wasn't that long, but within that 5 to 10 minutes that everything went up the spout, the anesthetist couldn't control the patient and the patient died. So I don't know whether this is reaming right through. The only time that I've had, and I have had, the only time that I've had some youngster who I was assisting late at night just to do a fracture neck of femur, he reamed right through the base, through into the bladder and into the deep vessels. And that was a very interesting case. So then I had to convert to my Cape Town days. I don't think I could now, and open the patient's belly and clamp everything and shout for both the urologist and the vascular surgeon. It was a very famous night in Bristol. So I don't know what is tipping those 144 patients. And there might be people who in fact are so problematic and have such high comorbidities anyway. You could rationalize that maybe it was the robot didn't have that much to do with those 144 deaths. So my answer is, I don't know. But that's the figures I give you. It was interesting. It's worth somebody like you who likes information tracking that site every few months, because boy, do you find out about the different hip devices that are causing problems. It's very, very interesting. You can start to pick it up. You go and look there and there are 10, and you go and look 3 months later and you see the same device is giving now 100 problems. And if you're using it, stop using it.
For this difficult spine, pelvis, hip axis patients, is dual mobility the solution, or is there a problem with dual mobility as well?
Oh, have we got anybody talking? We've got somebody talking on dual mobility in the BHAC. We've got Alistair Hart talking on the. Look, of course it is. I think dual mobility, dual mobility for me comes in when I'm doing my 4th or 5th revision. I mean, I get to the point where I realize I've got no muscular control, and then I use dual mobility. I don't use dual mobility in my primary patients. I really rely on my skill set to get my cup into position, and you've operated with me for a year. So my check in terms of feeling in the front for impingement with my fingers and doing the full range of movement. If I get to a situation where I really realize that with an increased offset, I can't control the patient at 75, 80 degrees, and that's my cutting point, then I would put in a dual mobility cup, then I would use it. So you're right. If I were a smart surgeon and I got somebody who was a 45-year-old lady who was hypermobile, and I had a high profile in India, and I thought, my God, I'm being smart enough to pick this up at consultation, I would call in the double mobility cups to be in theater so that I wasn't going to fall into the trap of having a dislocator on my hands. And I think I've made it simple. I think the relevance of what Ian Clark and Lezesnik have done in Paris, because it's all their work really. The Parisians got the kudos, but it's Ian that does all the clever work behind it. And that's how I know so much about it, because obviously Ian talks to me about it. I think it doesn't translate into reality of what we do day to day. I mean, do you really? But I think positioning of the posterior pad does. I think if you put it higher up in the back, you're in trouble. So I think what translates is spotting the lady who is definitely hypermobile, sticks out her elbow, she bends back. That's the one that you've got to think of. That's how it translates into reality. Amar.
Great.
Yeah, thanks, Evert. You did mention about the heterotopic classification to be a little challenging there. So, I mean, really concerned with that, obviously. The data being high on the robotic. And is there a way that we can sort of work around? I mean, hip, I think Sri knows, and I'm sure you guys know more about it. India, the hip probably would be lesser number compared to the knee, but still, sure. I was just wondering about it. If you could put some thoughts on the heterotopic.
Yeah, I do have thoughts. So when I first started, and I go 2 or 3, as you know, I go 2 or 3 times to the States, and I operate with about 5 or 6 different surgeons who were with me when I was at Massachusetts Gen, and I've kind of remained friends with them. And I go and watch them. And most of these guys are skilled surgeons, and they've become used to robots. Now, I think the trick is, if you can't do minimal invasive surgery, and then you try and do minimal invasive surgery with a robot, you're in trouble. If you open the wound to a reasonable position, and you're very good with soft tissue, and you are able to use retractors to keep everything out of the way, then I don't think in the situations where you're skilled with a smaller incision and you're skilled at retraction in a wider incision, I don't think those experienced surgeons are getting into trouble. It's the ones that actually go halfway house to a big incision. They've got a larger beast man, they stick it in, and I just see this reamer ripping up. When it comes out, it's still firing, it goes into the soft tissue, then they cut a little bit more off to get the position of the leg out of the way to see visually a better position in the cup, and that's where the trouble starts. So I think what we're seeing in this group of papers, and it's not much, you can actually get all the bibliography. I think what you're seeing is this sort of, as you mentioned, the standard approach to just doing it, looking at the robotic screen and not bothering about what's going on in front of you. And a high percentage of them are turning out with soft tissue damage. So I think You have to first become a very good technical surgeon and then turn to the robots. You can't ignore it. And so I think that's what we're seeing. And I think you can get around it. I think you can get around it.
Mez, any questions that you got?
Mez is asleep.
Oh, no questions. Fantastic talk, Evert. Yeah, and I agree with you with regards to the dual mobility side of things. I think I would be cautious using it in the primary setting, but in certain groups of individuals, you just need it there as a reinsurance, just in case.
Absolutely, absolutely. We've just written a very good paper on impingement and dual mobility, so I didn't want to really go into it, but it's not happy reading.
No. And the other thing, just to follow on with that, is there is some evidence through the NJR in the UK that dual mobilities don't do as well as people think that they do or they might do. Yeah. Agreed.
So great. So Dr. Ashok, if you don't have any questions, we'll sort of move on to the next question, session really. Any questions from our Ortho TV side?
Hang on, I think there's a question, something is mentioned here.
Yeah.
Jason is asking, is there a risk too much reliance on the robot?
Well, I think we've just mentioned it, haven't we? And I think that's it. I think that's why the RoboDoc got into trouble very early in the United Kingdom. I think to actually just suddenly give up and go automated and then rely on a robot. And of course, Shree's asked me beyond, as the gentleman who's asked the question is, I think in time to come, this may be all resolved. But at the moment, that reliance, you first learn to be a skilled surgeon, then you can turn to your robot afterwards. And then, you know, honestly, when we did the last sessions with Stryker, I could see that a uni-compartment knee was nearly perfect for a robot, nearly perfect. So I can already see the difference between the different operations. But, you know, you knock a nice medial hole, it's enough of a gap for all the robotic stuff to fit in, and it just literally does the work for you. But the other operations that are not necessary is easier than, and of course a knee is easier than a hip, but it will come. It will come because of that opening gambit that I was discussing, that I think what we are having is we're having society and the controllers of healthcare take away the simple thought processes that we all understand, because we face patients every day and they don't. And it's being removed from us. It's going to fly away from us.
So thanks, Jason. Thanks for that question. So I think we'll move on to the next part of it. So this will be a presentation from Evert about the history of BHAC, Bristol Hip Arthroplasty course, creating and passing on a legacy to the hip surgeons across the world. So Evert will present a few slides, and then I'll present a video from this end. Yeah, I can see.
Got it?
Yeah, I can see that. Fantastic.
Thanks everybody, and thanks for listening. It's very kind of Sri to give somebody like me who can't stop talking two talks in one go. So the Bristol Hip Arthroplasty course has been magnificent. And again, I'm going to turn to somebody like Mez, who's been a treasure. The one thing I did for him is I made sure that he got his job in Bristol. And since then, he's been an absolute treasure and a massive supporter for me, both in the clinical setting and in the BHAC. I think he's a busy man, so there were wise reasons why I didn't make him lead, because I think he is so superb at other things. I would rather help further his career in other domains rather than specifically the BHAC. So this man is a giant. He is Louis Solomon. He was my professor in South Africa. He did enjoy me as a as a student and as an orthopedic trainee. And then because of the issues relating to apartheid, he decided that he would leave South Africa. And at that stage, many of us were considering to do so. He left after the appointed professor in Bristol was tragically killed in a helicopter accident. And they had no one to turn to, but spotted Louis Solomon, who was at the relative sort of end of his career, and invited him to become professor in Bristol. Interestingly enough, and John would like this because John is just a remarkable man in whatever he does. Louis Solomon was, I think, one of the youngest trainee surgeons to get his doctorate at Harvard at about 34 years old. And his doctorate was to develop or let us know and the world know about the different forms and shapes of arthritis. So that's was a magnificent thesis. And interestingly enough, I must say, just in case the audience is already whispering, when I arrived in Bristol, Louis Solomon had nothing to do with my appointment. He wasn't even involved in my appointment and wasn't effectively in place. So just to let you know that there wasn't a Jewish Johannesburg, Cape Town link. He came into Bristol 1989 and said, we haven't got any courses on the hip and we haven't got any courses on the knee. And why haven't we got any spinal courses? The first course that he triggered in was something that he called the debates about hip replacement. He was so busy and so involved in so many other things that he really decided within 2 years that he could not actually find the time to do all the work to set up something. And Sri will know how difficult it is to set up these meetings. So he handed it over to John Newman, who it was an excellent teacher, knee surgeon, and was well known for his design development in union compartment knees. The thing about John Newman was he was an absolute precisionist. He really could work to a timetable and found it very, very easy to drive the debates about hip replacement forward, even though he was a knee surgeon. Halfway through the 1990s, getting to the late 1990s, he started to feel that he wasn't in control of the knowledge of the hips and asked me as the senior registrar, because I had to come back to Bristol to do 1 year to get my, I got a scholarship to go to the States. So I had to come back in first to get the scholarship, which I won from the British Orthopaedic Association. So John then hinted that he would sort of like me to take it over. And the course was very interesting because in those days, it wasn't sort of the new millennial way. Everybody had to attend, literally everybody. You literally were not signed off unless you were in the operating theatre. It was all day Friday and Saturday morning. And as I said, it was mandatory. And he wrote that wonderful textbook on orthopedics, which I think you probably all know, which he did with his friend Apley. So this was about him. He loved anything to do with arthritis. His knowledge on hips and arthritis were phenomenal. He always used to say that our aim is to give the highest quality benefit to the patient and aim for a hip to life. And of course, he was great friends with Sir John Charnley. And I was sent to Wrightington for a year to learn how to do hips before I sort of came back to Bristol. John tired, and he said in 1998, please take over the debates about hip replacement. And this is our first little program that we had. We had Bill Leone, who was phenomenal. We had Prof. Lawrence Siddell, who you may or may not know was one of the greatest protagonists of ceramic on ceramic. Ian Learmonth was invited. He just sort of arrived and was rolling around Bristol. He hadn't yet got the professorship. We had Professor Tony Miles, bioengineer from Bath, David Murray, who wasn't yet a professor, Martin Porter, James Richardson, who had just obtained the professorship at Oswestry, and some others. And the last two, my good friends, Ian Stockley and John Timperley, sort of made up the course. So again, I said the course was all day Friday and Saturday. It was mandatory. What was interesting, in 1990, I went up to London, met Michael Freeman, who came down and argued for his neck-sparing design of total hip replacement. I put his name in there about this course because in terms of intellect, he was one of the most remarkable men that I ever met. I think he was so intellectual, he sort of sequentially changed his wives as he went along. He was quite a remarkable surgeon. Paul Walker designed many great things for many of the great companies, particularly knees, and he chatted about cementous fixation. And Graham Gee was at that stage in 1990 just getting excited about impaction grafting with Robin Ling in Bristol, in Exeter, sorry. So these are what it looked like. These are how it started as debates about hip replacement. It moved on, and there's a picture from 2012 and others, and just showing some of the touching things. We were obviously bowled over by the metal and metal disease. The slides at the bottom really show my influence with Heinz Wagner, and I was always sad that he never came, but it was a remarkable development of a course for hip surgeries. So Southmead Hospital was the venue, and then it shifted to the Bristol Zoo because the venue at Southmead Hospital literally squeezed everybody in, and we could get about 50 people in. The zoo auditorium, we were able to get in about 60 or 70. And then in 2005, I thought we were getting so big and people were phoning me up to come and speak. And why wasn't I getting invited? That sort of thing from different people in the United Kingdom. And I shifted to the Marriott Hotel because it had the space in the ground floor, which had a fantastic lecture room, but had a massive space for the product companies to come and show their wares. And as Shri will know, that link between the product companies and the surgeon is always a dangerous one. And you should never be beholden to them, but you should also understand, and I learned and understand this, that you have to work with them all the way through your life to get the best out of everything that you can do. And that was the prime site for getting all of this magic combination or magic cooking together. So I've organized it all the way through. This year, I'm basically giving it over a little bit to James. And I could see at the supper meeting that we had at my house that they basically saw that my hair was starting to get gray and they didn't want me around that much. At the point where we shifted to bigger venues, I decided that we had to brand the name, and I called it the Bristol Hip Arthroplasty course, the BHAC, and it's got its own WW. And the cost of the course increased, and they're still trying to make me put it up, but I always turn to Mez to ask him how we're doing. But in 2020, which we didn't have, the cost was going to be $225 per delegate for the 1.5 meeting, which is still good. I show you some reflections in the development. In 2007 is when I met Alistair Hart, who became a very good friend of mine. And he talked about the Alval Norwich story. We even had talks from Switzerland on the thrust plate. We had the second wave of resurfacing by Derek McMinn. We had cement removal techniques of Sarah Murad Alwood, who you know is the royal surgeon. And we got on famously, and I've spent many a moment in London operating and doing revisions with her. And Anthony Cattrall came and discussed the painful hip, and that's obviously in the child because he was a famous pediatric orthopedic surgeon, and I met some wonderful people as the course developed. Well, the BHA group was Tony Ward, and as I went on, I thought the whole thing is a team approach because I'm a cricket rugby man, and I thought the only way to do this is share this with good people in Bristol. So Tony Ward came on board first many, many years ago, and he is my good friend and wingman. And then Mez came along to be my second wingman, and then we brought in other people who intellectually we thought would add spice to the course. And so James Burstock, Prof. Richie Gill, Richard Baker, who does infections, and Michael Whitehouse, who's also like Mez now, who's a different kind of professor, came into the fold. In around 2011, David Penford, who was part of developing the brand for Proctor Medical, came to speak to me, and he has had a massive impact on the way we brand this Bristol hip arthroplasty course, and is really a welcome member amongst the people who have a passion for the course. The BHAC has definitely witnessed a paradigm shift in orthopedic surgery through the 20 years that I've been involved with it. And we've also seen the changes over time in healthcare of the patient. And it's been for me quite remarkable. And I can sit with John Skinner and Esther Hart in London, and we can talk about these changes. And if you haven't been around that long, you realize what's made. And the picture of Tony and I is a recent walk on a Sunday for old people over 80 who need exercise. I put down giants and friends, and there's a list. And this is not a list in its entirety, but these are some of the people who've influenced me, I have learned from, and have been at the meeting providing wise words. But the bright one is Professor Ian Clark, whose picture is on this slide. And he doesn't think in health terms. He doesn't think in patient terms. He thinks in exact science, engineering, bioengineering terms. Otherwise, he doesn't want to know. So he's quite an interesting man to dovetail with, because he just thinks in a different mode of thought as to an orthopedic surgeon. What did we go through? Many, many things. The internet, we certainly went back and forth to consent. This is the core of the course: arthritis and hip arthroplasty, hip approaches, MIS, leg lengths and dislocation, and all the other complications that we get in hip replacement. Robotics, we've touched on a number of times. Prosthetic hip and joint infection never goes away, of course. Bearing surfaces, articular wear bearings, materials, revision hip surgery, and the issues in the Western world of obesity are some of the things that we've had a look at. And I suggest this is not necessarily my favorite quote, but it's certainly one of my 5 favorite quotes. Never forget that progress is impossible without change, and those who cannot change their minds cannot change anything. Sri, thank you very much for inviting me.
Thanks, Evert. Thanks for a fantastic legacy talk. And really grateful to you for putting a minnow like me in the list of chains of orthopedics in the world. Thank you so much. So I think what we'll do now is a brief video from my end on the legacy talk of BHAC. I'll share that just in a minute. So yeah.
While Sri is sharing it, I mean, I was just wondering about, before your second slide came on with Michael Freeman, I was just wondering how come Michael was not invited to, BHAC, and then you threw the card. It was pretty wild. And I mean, after having gone through his course in London, we thought that is the best hip, Anyway, that's history now.
Oh, such a bright man.
So I'll just start the video now. So. BHAC is starting in another few weeks' time, really 3 weeks' time. So there is another presentation on the BHAC 2021, the academic feast. I'll just share that video. So after that, Evert is going to just invite all the Indian delegates to come and join and participate in this meeting. I'll just leave at this page really. So those doctors who wants to register for this important meeting can register through this link. So if you're watching this program through your mobile, you can take a snapshot or a screenshot and register through this. And now I request Mr. Evert Smith to invite the Indian delegates for this incredible meeting.
You happy I speak from my little box?
Yeah, that'll be perfect.
Well, for me, as from where I originated from and gaining the friendship of you guys from India, having two magnificent Indian fellows, Ashish Fadnis and Srikanth. Unfortunately, I asked Amar to become my fellow, but he refused. And I couldn't ask John to become my fellow because he would have laughed at me. So I really think there's a great friendship, a long-standing friendship for many years to come. I have Mez to remind me of his original countrymen, just to give me a nudge now and then. And if I had my way, I would get GOSI to pay for all of you to come over to Bristol to be at the course themselves. Long may GOSI go from strength to strength, but I invite all my friends and colleagues from India to participate in what I think actually making a comeback after missing last year is a really, really strong course. I mean, I have my personal biases, but the one that really thrills me, because I've been on a board on metal and metal with this lady, is Sophie Williams, Professor Sophie Williams. She is just fantastic in terms of her knowledge and wear and degradation. But there are many courses, and you can pick and choose which ones you want to, and you can go to sleep during others and watch a little movie on the side or whatever, but really come to Bristol on Zoom mode, and we would love to have you here. I've invited chaps away from there to come and speak, but unfortunately coronavirus pandemic got in our way and looks like it's not going to go away for a long time, so travel is difficult. But I think Mez and I invite you all. Agreed, Mez? Agreed. Welcome to the BHAC.
Thanks, Evert. Thank you so much.
Definitely.
Thanks, Mez.
Yeah, agree with you, Evert, completely. Come and see the bridge behind me, and come and join the meeting.
Absolutely, the Clifton Suspension Bridge. So thank you. I take this opportunity to thank Mr. Evert Smith. He has come on a Saturday and spent teaching us incredible aspects. Really big thanks to him. I know there's a very critical South Africa versus England going on, and I'm looking for South Africa because it's going to make that group very interesting in the World Cup cricket. So I don't want to keep him for long. If there are any questions in the Ortho TV or in the chat box somewhere, we will ask Evert, and then we'll let him go. So
yeah, that's fine. I'm happy to say, and I also want to listen to Mez, but thank you so much. And I'm sure Mez and I will talk in the next couple of days. Thank you all. John, Ashok, Amar, everybody. Thank you.
Thanks, Evert. Thank you so much.
Have a great weekend. You have a nice weekend, Evert. Goodbye.
See you. Okay, so we will sort of move on to our next presentation. So, a little small break after Orthopaedic. So, let me go back to my creative corner, really. So, yeah, there it is. So, let me share this slide. Amma, can you see my screen here?
Yeah.
Yeah, brilliant. So
you need to put it on the presentation mode.
The presentation mode, okay.
There you go.
Okay, great. So excellent. This is something I'm very, very close to my heart, really. A lot of questions come, why this pandemic, why this destruction, and so many things. And often crisis gives us the opportunity to find answers, really, to what is going on. So I started this creativity corner. It was there in the last meet, the master's course, when Mr. Smith and Professor Listerhart were here. And, this sort of helps with our lateral thinking, really. And I picked up a couple of points from Professor Mohit Bhandari, with whom I and Amarnath know quite well from Canada. And 20% of activities give human beings around 80% of satisfaction. A 5-year-old has got around 98% creativity compared to adults who have got only around 2% creativity. This is from George Land and Beth and German in 1993 paper. When it comes to performance acceleration, the paradox is for greater impact, one needs to sort of slow down to reflect, what we have done and where we are going, and this also been published really. And I'm nearing 50 now, and it took this long for me to understand the meaning of human being, really. So what you say, a human being. So we are sort of the being, is the creative, wise, conscious self representing unity and oneness, and which spreads love in this world and universe, while the human is the form or the physical aspects of us in this physical world. And by its very nature has multiplicity, and unity is almost impossible because, genetically no two human beings are the same. So as many 8 billion people are there, there will be different human beings really. So, thinking plays a subordinate part in the decisive phase of creative work. So it's a very interesting thought that why majority of scientists are not creative. It is not because they don't know how to think, but because they don't know how to stop thinking. So there's a very famous example of Archimedes, where the Eureka moment, he was not thinking or putting pressure on his mind. He was just relaxing and chilling out and in a sort of meditative state where the creativity came into being. And that's a secret that one can experience really. I think in the second wave of pandemic, I myself discovered a new form of meditation called mirror meditation. It's so simple. I always want to simplify things. And I was myself surprised how I could discover a mirror meditation. So that's for a different day. So moving from science to metaphysics, the one such talk on innovation, creativity is from our second speaker, Professor Mehool Acharya. I have introduced him already briefly for those who joined late. He's an honorary professor of orthopedics at Wales, and he's been a consultant in North Bristol NHS Trust for more than a decade, really. And he, is well known in India as well, particularly in the pelviacebular circles. And he's going to discuss today about soft tissue algorithm to reach a forgotten knee after total knee replacement in 2021. It's a very challenging talk and a futuristic talk. And really thank Prof. Acharya for coming and enlightening us regarding this. I'll stop sharing. Over to you, Mr. Acharya.
Shri, thank you very much. It's always a pleasure to be part of this group and this meeting, and thank you very much to Dr. Amarnath, Dr. Ebnezar, Dr. Srikanth for the invitation and the talk. As Evert said, I'll echo what Evert has said regarding the teamwork, the history behind the BHAC, and I'll encourage you all to try and come and visit us in Bristol and be part of the BHAC. Can you all see my screen?
Yes, as we can see alignment and soft tissue.
Perfect. So, it's great to be part of this meeting. And Shri, I really appreciate you giving me this talk because, as you say, it's a challenging topic to speak about. And, we are far from where we want to be to try and achieve perfection in total knee arthroplasty. And so hopefully what I'll do over the next 30 minutes or so is give you some principles you already know about, maybe try and build on some of these principles, try and maybe share some new knowledge with you as well, hopefully, and then try and think about how we can look towards the future and how we can try and optimize the function that we want for these patients undergoing a total knee arthroplasty. So the topic is soft tissue algorithm, and I've put alignment in there as well, because when you look at knee replacements, alignment and soft tissue go hand in hand, so I've put them together. Again, just to reiterate what we've spoken about and what Evert has spoken about and what Shri has spoken about and what GOSI and BHAC are all about. This is a quote from Henry Ford, and it's very poignant. So coming together is a beginning, keeping together is progress, and working together is success. And this meeting and all of these meetings that have been put together by Sri, by Dr. Amarnath, by Dr. Ebonisa, are due to hard work, working together, creating success. So what I'll do is we'll talk a little bit about the problem and the size of the problem. We'll talk about understanding what the forgotten knee actually is, a little bit about normal anatomy and normal alignment, and then what a lot of people use to align their knee replacements, the mechanical alignment. We'll touch a little bit on personalized alignment and the various different facets of that. And then we'll look at soft tissue balancing and various technologies that we have available to try and improve the aligned, balanced knee. So this is the problem. Well, by 2030, the volume of revision arthroplasty is projected to increase 5-fold. If we look at some evidence available, nearly 3% of total knee replacements will require early revision, so within 2 years. And when you look at reasons for revision, instability is estimated to lead to just under 20% of revisions in total knee arthroplasty. And this is usually attributed to improper soft tissue balance or component malalignment. And so you see the picture, the X-ray at the side of your screen, and that shows significant instability. Well, we know that imbalanced flexion and extension gaps relate to post-operative range of movement, which is reduced or abnormal compared to the opposite knee. We know that 20% or up to 20% of patients still remain dissatisfied with their outcome after a knee replacement. And a proportion of these patients have ongoing pain, loss of motion, loss of function. So what is the forgotten knee? Well, putting it simply, a forgotten knee is a painless, asymptomatic knee, which is identical to a normal knee, or the opposite knee, if they haven't had an operation on that. So is it possible to have a forgotten knee after a total knee replacement? Well, looking at some of the literature there, so this study in 2018 looked at 470 patients with a minimum 5-year follow-up. And it's a really easy question because it's binary. It's either yes or no. And so these patients were asked whether they had a forgotten knee after their knee replacement. And 48% of patients, just under half, had a forgotten knee at 1 year after a total knee replacement. This other study in 2015 by Ahmad looked at 584 knee replacements, and over 90% of these were performed for severe osteoarthritis with fixed deformities. At a follow-up of 6 years, they found that a forgotten knee was present in their cohort of just over 42%, so just under 43%. And what they also showed that only 66% of total knee arthroplasties with a perfect outcome score, a functional outcome score, reported that they had a forgotten knee. So that shows that even if you have a perfect functional outcome score, you may well not have a forgotten knee. So your knee may still trouble you. So what it shows is that these functional scores may not be the best way for us to gauge functional outcome in these patients. So what about negative and positive correlations with a forgotten knee? Well, there is a negative correlation with dysplastic patellofemoral joint arthritis. If you oversize the femoral component, this has a negative correlation with a forgotten knee. if you have a tight extension gap, femoral lengthening, or tourniquet time, all of these features have a negative correlation with a forgotten knee. So you're less likely to have a forgotten knee. Things that don't have a correlation with a forgotten knee have been reported to be gender, high BMI, whether you use a cemented or cementless component, and a pre-op Oxford hip score. Just for your information, the forgotten knee score is a score which is scored out of 12 different parameters. And each question you answer never, almost never, seldom, sometimes, and mostly. And then you put all the scores together. You divide the total score by the number of completed items. And then this is multiplied by 25 and subtracted from 100. This gives you a forgotten knee score, and the higher the score, the better. So moving on to alignment, well, normal anatomy is really important to understand. And when we look at mechanical alignment, this sort of suggests that most people will have normal anatomy, or will have a normal range of anatomy. So we'll talk a little bit about mechanical alignment, what it is, how it's achieved, some of the results associated with mechanical alignment. But it's important to understand that it's one particular technique, although you will have a range for all patients. And this may not be the best thing for all patients. So traditionally, the mechanical alignment was the gold standard for total knee arthroplasty. And to obtain mechanical alignment, the femoral and the tibial components are positioned at 90 degrees to the tibia and the femoral mechanical axis, as shown in the X-ray below. Mechanical alignment was driven by equalizing the load on the implant to reduce the wear and loosening, rather than trying to restore the normal kinematics and function of that knee. When we look at knee replacements that are aligned using mechanical alignment axes, the functional outcome is inconsistent in a cohort of patients. We've already said that, you know, up to 20–30% may not be satisfied, may have significant discomfort in their knee. Some patients have discomfort during activities of daily living, and these cause a great deal of patient dissatisfaction. So because of this group of unsatisfied patients, mechanical alignment and the theory and the process was challenged in the late 1980s. And what people have tried to do since then is to try and improve the functionality to try and recreate native knee alignment. And so, as I've mentioned already before, mechanical alignment was very similar for all patients and not personalized. So moving on to personalized alignment, what does this mean? What does it really mean? Well, when you look at personalized alignment, you can group it into 4 different types. So kinematic alignment, inverse kinematic alignment, restricted kinematic alignment, and functional alignment. And what I'll do is I'll talk a little bit about what each of these are to try and understand these a bit better, and try and hopefully get across to you how balance is achieved in each of these situations where you personally align the knee replacement. So we'll start with kinematic alignment. Well, this was first described by Howell in 2006, and it's an individualized patient-specific technique. The aim of kinematic alignment is to resurface the knee with restitution of pre-arthritic anatomy and preservation of soft tissue. So in kinematic alignment, the knee is represented in 3 kinematic axes in respect to the distal and the posterior joint line. The kinematic alignment technique aims to co-align these axes and the joint line of the implants with the 3 kinematic axes and joint lines of the native joint. So that's what we're trying to recreate. These are the 3 axes that we're trying to recreate around the femur. So we have the distal joint line, we have the posterior joint line, and you also have the rotational axis as well. So in kinematic alignment, the surgeon resurfaces the femur, maintaining the pre-arthritic femoral joint line obliquity, and then adjusts the flexion and extension gaps with resection of the tibia. So it places emphasis on ensuring that you kinematically align the femur, and then any adjustments that you make for flexion and extension and balancing are made on the tibial side. It restores pre-arthritic ligament lengthening. It does not create a gap imbalance, and it minimizes the need for releases. Well, what's the technique? Well, in a nutshell, I've already mentioned it to you, but essentially you do a measured resection of the femur first. You estimate the amount of individual knee laxity and bone loss. So the distal femoral cut, as mentioned in this diagram, is cut first, which is that cut there. The cut you then make is the posterior femoral cut, and this is parallel to the posterior condylar plane. And this can be measured and checked by measuring the thickness of the cuts that you've made. This then kinematically aligns the femur and the femoral component. Any further adjustments and balancing of the flexion and extension gaps are made on the tibial cut. So if during trialing the soft tissues are tight or lax, then adjustments are made to the tibia, as I mentioned. It is highly reproducible, and it can be performed with standard instrumentation. It can also be performed with computer navigation, personalized instrumentation, and robotic assisted navigation. But what about the results of kinematic alignment? Well, a systematic review looked at 5 different randomized controlled trials. 4 of these randomized trials showed no difference between kinematic alignment and mechanical alignment at 2 years. 1 of the RCTs showed that there was a significant difference in Oxford hip score at 2 years, and a significant difference in range of motion, function, and pain between kinematic and mechanical alignment. Results of patients with kinematically aligned knee versus a mechanical aligned knee on the opposite side. So these are patients who have had already a knee replacement on one side, which was mechanically aligned, and then they've had a kinematically aligned knee as well. And what they found is that in 83% of patients, they were happy with the mechanically aligned total knee replacement. 92% of patients were satisfied with the kinematically aligned total knee replacement. The mean forgotten joint score between the two was significantly higher for the kinematically aligned knees. Well, what are the concerns with kinematic alignment? Well, most of the problems are related to the tibial cut. And if you take more of the tibia, you resect more of the tibia, this can significantly create a greater laxity in valgus, certainly between 30 and 90 degrees flexion. Even small recuts can sometimes create asymmetry when you look at flexion and extension gaps. So it's important just to be aware of this. Other concerns, well, there is a potential increase for stress on the implants, especially when the deformity increases and the alignment deviates from the mechanical alignment. So these are the severe deformities, and these can sometimes create quite a lot of stress on the implants, on the medial side. And as I've highlighted there by Nakamura in 2017, this is more severe for the moderate and severe arthritic patients with significant deformities. Okay, so what's inverse kinematic alignment? Well, this is the opposite to kinematic alignment. So in kinematic alignment, we resurface the femur first, and then any adjustments were made on the tibia. Inversely, inverse kinematic alignment is where you resurface the tibia first, and then you adjust the gaps by adjusting your femoral distal and posterior cuts. Well, what are the advantages? Well, by cutting the tibia first and then moving on to the distal femur and the posterior femur, it allows you to independently manage the flexion and extension gaps. It is challenging to perform with standard instrumentation, and so robotic assisted systems and computer assisted systems can be very, very helpful in achieving inverse kinematic alignment. Here's a surgical technique for inverse kinematic alignment, and this was described by Winnick in 2020. The tibial implant is positioned first with equal resection of bone, both from the lateral and the medial side. And again, on this schematic diagram, you can see that the first cut now is on the tibial surface. The goal is to restore native medial proximal tibial angle within a safe zone. The tibial slope is predetermined by the pre-arthritic medial tibial slope. You can see that the second cut that is made in inverse kinematic alignment is the distal femoral cut, and that will balance your extension gap. The third cut that is made is your posterior condylar or posterior femur cut, which will balance your flexion gap. So, as we've already said, the femoral implant is positioned to restore the medial joint line, both in flexion and extension, and this is determined by those two femoral cuts that you can make. You aim for a residual laxity of between 1 and 3 millimeters on the lateral side and 1 and 2 millimeters on the medial side when you're looking at your flexion gap. And when you're looking at your extension gap, you aim for a residual laxity of 1 to 2 millimeters, both medial and lateral sides. The problem is that readjustment of the femoral cuts after initial cut and trial are very difficult using conventional measures. Now that we have robotic assisted surgical techniques and computer assisted surgical techniques, recutting the femur or the tibia may be easier, but using conventional techniques, this can be quite challenging. What about the results of inverse kinematic alignment? Well, Winnick et al. Looked at kinematic alignment versus adjusted mechanical alignment, and what they showed is that there was no significant difference between the two at 12 months. There was a higher rate of satisfaction and post-op Oxford knee score in the inverse kinematically aligned group, especially for those patients who had a pre-op varus deformity. Moving on to the third type of personalized alignment, so restricted kinematic alignment. And Vendatoli in 2017 recommended safe zones for kinematic alignment, and they suggested that you should try and avoid reproducing extreme anatomy. So those patients who have extreme varus or valgus, you don't want to overcorrect them into the normal anatomical or normal mechanical alignment, because you will push them over the edge, you will correct them so much that actually that will cause other problems. And so restricted kinematic alignment is a hybrid option between mechanical alignment and kinematic alignment. And this algorithm involves modification of bone cuts within a cell safe range. And these are mentioned in the paper by Ventatoli. However, it really follows the technical principle of a kinematically aligned knee. There's quite it looks complicated, but when you're doing this, it's quite a straightforward algorithm which takes you along different paths as to what you should do depending on whether you've got a hip, knee, ankle axis of less than 3 degrees or more than 3 degrees, and whether you've got a medial proximal tibial angle of less than or more than 5 degrees. Again, if we look at the results of restricted alignment, 2,475 total knee replacement cases, only 49% of them required a restricted kinematic alignment. The remaining 50% or so had unrestricted alignment. So they used the restricted kinematic alignment for the severe deformities. Blakeney and et al. In 2019 looked at CT scans and tried to simulate flexion and extension gaps according to kinematically aligned knees and mechanically aligned knees. And they found that there was a greater gap imbalance on these simulated scans in the mechanically aligned group. So what about functional alignment? So moving on to the fourth type of personalized alignment. Well, this is achieved by manipulating alignment, bone resections, fine-tuning, component position, and soft tissue releases. And it's to obtain balanced flexion and extension gaps, which we've talked about various ways of doing. It is precise to within 1 to 2 degrees and is especially helpful when used with robotic assistance. So what's the surgical technique for functional alignment? Well, once the initial bony cuts have been made and the components have been trialed, if there is a soft tissue imbalance, which is noted, then adjustments can be made with 3D software and manipulated to guide the recuts or releases. So again, when you have computer assisted or robotic assisted software, then it is easier to recut the femur and the tibia. When we're looking at functionally aligning the femoral component, again, we're looking at the 3 planes, the coronal, the sagittal, and the axial plane. And in the coronal plane, you want the femoral component to be positioned so that you can balance the extension gap. In the sagittal plane, your femoral component needs to be positioned so you avoid anterior notching. And in the axial plane, your femoral implant needs to be aligned to the transepicondylar axis to allow for the native rotation. When we're looking at the tibia and the coronal, sagittal, and axial planes again, the tibial component in the coronal plane is aligned to the mechanical axis and modified to balance the flexion and extension gap. In the sagittal plane, the tibial component is set to match the patient's pre-arthritic slope. And again, this is specific to the patient. And in the axial plane, the component is positioned according to the Agaki line to guide rotation of the tibial component. What are the results of functional alignment? Well, several studies have assessed the accuracy of robotic-assisted surgery. Sears et al. Looked at CT scans post-total knee arthroplasty and assessed image-based total knee arthroplasty. And what they found is that in 93% of cases, the surgical measurements were accurate to within 3 degrees of CT measurements post-op. Marchand et al. In 2019 used pre-op CTs and robotic-assisted total knee arthroplasty and showed that these resulted in well-balanced knees. So moving on from alignment to soft tissue balancing, and we'll spend the next 10 minutes or so talking a little bit about different ways, different techniques to try and balance your knee replacement. So you have static techniques, and there are two standard techniques for this, either a measured resection, where you take a measured amount of bone, and then you balance or you release ligaments to try and balance the knee, or gap balancing, where you try and assess the ligaments, assess the soft tissues, and then create your cuts in response to that. So what you may well do is balance your ligaments and then make your bony or osseous cuts. You also have dynamic soft tissue balancing, and two main ways of dynamically balancing your soft tissues are computer-assisted navigation, gap balancing, and we'll talk through these, and intraoperative tibial tray sensors to try and gauge soft tissue balance through an arc of motion. So these are essentially your static ways of balancing. So you can use spacer blocks. And when I started, this is what I did. I started using spacer blocks. I sometimes used laminar spreaders. I definitely used trial implants to assess my soft tissues. I've used tensioning devices, but didn't really get on very well with these. So I've used the first three quite a lot to balance my knees statically. If we look at computer-assisted navigation and look at various companies and various techniques that have incorporated navigation with soft tissue balancing, we can see that there are various systems. So there's the Galileo system by Smith and Nephew. There's the Ortho Pilot by B. Braun, the Vector Vision by Brain Lab, the SIMI total knee replacement, which is the sensor tensor, and the knee aligned CFS system by Ortho Align. If we look at the mechanical outcomes of using computer-assisted navigation for soft tissue knee balancing, we find that an accuracy of gap measurement increases to within 1 millimeter, which is pretty good. Accuracy of mechanical axis alignment is achieved, and the soft tissue balance measurements were more accurate with the patella inverted. So a lot of the time you use various balancing devices with the patella everted, but a lot of the studies have shown that actually that doesn't give you the most accurate soft tissue balancing measurement. So you need to invert the patella, have the knee in the functional position, and then put it through a range of motion to ensure that you've achieved best balancing. What about the clinical outcomes of computer assisted navigation and soft tissue balancing? Well, the study by Peng et al. In 2011 showed that it was more precise soft tissue balance with decreased anterior laxity in 20 degrees of flexion. These patients had better functional scores, the Oxford Hip score, at 6 months and 2 years. Singh et al. Also looked at computer-assisted navigation and soft tissue balancing, and they found that their patients had a higher knee score and an Oxford Hip score, Oxford knee score, I should say, at 2 years. Lee et al. In 2010 showed that using computer-assisted navigation, you had a more accurate gap balancing, but equal clinical outcomes compared to conventional methods of resection. So what about the cost associated with this? Well, these are both more accurate and expensive than conventional total knee arthroplasty. And so is it the right thing for everyone? There is a mean cost per case of between $1,000 and $1,500, and this needs to be borne in mind. However, as with most things, as people use it more frequently, this will drive the cost of that per case down. So moving on to the intraoperative sensors. So these are the sensors that you insert between the trial implant, so the knee femoral component and the tibial component, and this gives you an idea of the pressures and whether they're equal throughout the range of motion. Well, one of the first operative sensors was reported on by Wasilewski in 2004, and this is a picture from his original paper. And so you see the tibial insert, you see that it's attached to a sensor, which then gives you pressure readings across the tibiofemoral joint. Currently, there are two sensor guided gap balancing technologies. There's the Verasense by Ortho and the eLibra, the dynamic knee balancing system by Zimmer Biomet, and we'll just run through what these are. The Verasense is a system where there is a device in the polyethylene insert, or the trial insert, which then gives you real-time feedback alluding to the balance of the tibiofemoral joint. The Verasense have partnered with Stryker, Zimmer Biomet, and Smith & Nephew, so it can be used with various different implants. eLibra, this is a device that Zimmer Biomet have, and what this entails is resecting the distal femur first, then resecting the proximal tibia, and then you insert your sensor, and then you have your trial femoral component, which you can then adjust in rotation, inflection, extension, etc., to balance the pressures on the medial and the lateral side. So you cut the distal femur, you cut the proximal tibia, you insert your sensor, and then depending on the balance of the pressures on the medial and the lateral side, this is achieved by changing the femoral component position. So what are the clinical evidence for these sensors? Well, the study by Goetz in 2013 looked at 176 sensor-guided total knee arthroplasties, and what they showed is that 87% of these were balanced, 13% of them were unbalanced, and certainly in the balanced total knee arthroplasty group, they had a better WOMAC score and knee society score at 6 and 12 months. If we look at the study by Golladay in 2019, looking at total knee arthroplasty with a Verasense, they found that patients with a balanced total knee replacement had a better forgotten joint score and knee society score at 6 months. Over the last couple of decades, there's been quite a lot of enthusiasm for robotic surgical procedures, and this has just rocketed. Robotic assisted surgical procedures have also evolved. They've improved. However, there are only few studies that have shown superior results with robotics when you compare them with computer-assisted navigation. So what about robotic soft tissue balancing? Although there are lots of robotic systems available, the BalanceBot, also known as the OmniBot by Corin, is the first and only robotic soft tissue balancer available on the market. And this is what it looks like. So essentially, what is shown here is you've got two arrays, one on the tibial side, one on the femoral side, and a stack system just to the back here, which relays information initially, and then once you've balanced the knee. This here is the balance box that you can see. And what it has is again, sensors for both the medial and the lateral side of the joint. And this then provides real-time information before you've made your femoral cuts. And once you've got your implants in position, your trial implants or your real implants, so that you can determine soft tissue balancing. The actual surgical technique was described in a paper last year, and what they did is they attached the tracking arrays to the femur and the tibia. The gaps were collated using the tensioning tool, and typically this the way this is done is that the proximal tibia is cut first, and the tensioning device is inserted. The knee is put through a range of motion. You then decide on the alignment, the rotation of your femoral component and your femoral cut after balancing the gaps. Once you've achieved that, you trial your implants, again, put the knee through a range of motion and recreate the soft tissue balance throughout the range of motion. Evidence for this, again, the paper looked at 121 consecutive knees using the Omnibot, and they found that the alignment and the soft tissue balancing was accurate to within a millimeter. And what they concluded is that robotic assisted total knee arthroplasty combined with a robotic tensioning system can predict post-operative gaps before the femoral resection. So before you've already cut, you can predict the gaps. And this allows to virtually plan the femoral implant alignment and to optimize gap balance throughout the range of motion. What we don't know yet with a lot of these systems is the mid to long-term clinical outcomes. We've shown, or what you can see from this evidence provided, is that the different types of alignment, whether you use computer-assisted navigation to assess your gaps, whether you use robots to assess your gaps, does improve the accuracy of the actual mechanics, but does this relate to long-term improved clinical outcomes? And that's still yet to be proven. So in summary, I've been through in quite a lot of detail the problem that we're all about to face when it comes to knee arthroplasty and revision knee arthroplasty. We've talked a little bit about what the forgotten knee is and what we want to try and achieve. We've talked about alignment, mechanical alignment, and then personalized alignment, the various different types of personalized alignment. So kinematic alignment, inverse kinematic alignment, restricted kinematic alignment, and functional alignment. And then we've moved on to various ways of soft tissue balancing, whether you use static balancing techniques, whether you use dynamic balancing techniques, and then just thinking about combining the balancing and the robotic techniques together, and thinking about the Omnibot, which, as I've mentioned, is the first and only robotic device which allows you to balance the knee as well. And so I'll stop there and maybe take some questions, but just to let you know that after the next talk, we have an Omnibot simulated surgery from the Corin group, which will show as a short video. Thank you.
Mes, thank you very much for this mind-blowing presentation, completely futuristic presentation where we are heading in knee replacement surgery really in the next 5 to 10 years. Thank you very much for that. And I certainly learned today new things about alignment, which I didn't know yesterday. So thank you for that. This shows why these meetings are important, because knowledge keeps on exploding, and unless we are up to date with the knowledge, it's we'll be left in in the 1970s or something like that, really. So thank you. I think Dr. Deepak Dave has also joined from HCG Ahmedabad. Any questions for Mez? Please ask, sir. Anyone you can ask. Dr. Dave, do you want to ask any questions?
Well, I think first of all, as you rightly said, it's excellent new things which we have learned. Really need to sit down and read this, the talk again and again to understand more about this. So I really congratulate and thanks for giving us a lot of insight. The robotic things have just started in India. It's on a big platform at the moment. And as you rightly said, to combine robotic with the soft tissue balancing, it's going to be the way forward. We really need to learn on this. And the Indian surgeons really need to get into this rather than use robot only as a marketing tool. I think what you have shown that to achieve the long-term results, I think you really need to use the technology well. So I congratulate you, and it was a very good learning experience for personally me. Thank you, Srikanth.
Yeah, thank you, sir. Thank you very much. Dr. Ashok, if there is any question there in the Ortho TV chat boxes, please put it on the chat box here. We are sort of slightly running behind schedule, so I will start preparing for my presentation. Meanwhile, Amar, if you have any questions, please feel free to ask as well.
No, Sri, I think you get on, because let us get to the surgical part as well. So it'll be great. Yeah, thanks.
Yeah, Sri, I apologize for taking a bit longer than
No,
needed.
not at all. I mean, it was very, very important, and I think that's what we learned a lot, and this was what everybody was expecting, really, Mess, because we have to really decode this and go slowly and take away something from it, really, and that's what you've done. I think it's an excellent presentation. Thank you for taking your time, really. So thank you. Amar, can you see my presentation? Is my slide is visible?
Yeah.
Yeah, I can see it.
Right. So this is the final didactic lecture of today's meeting, and this will be followed by real-life surgery about the Omnibot robotic system from Mr. Mehool Acharya. So this is a very India-centric talk, and also, where we are, I'm combining a lot of legal aspects in India with orthopedics and orthoplasty, really. The topic is titled Complex Knee and Hip Replacement Surgeries in India in the light of, CPA stands for Consumer Protection Act 2019. So this act got sort of passed during the pandemic, and it's now become a law now. And 2 days ago, the doctor group even tried to repeal this law by going to the Mumbai High Court, but the High Court refused. So this law is here to stay, really. So about my center, I didn't introduce in the beginning. Myself, I'm Dr. Srikanth Kane. For those who do not know me, I'm a consultant knee and hip surgeon. These are my qualifications, particularly proud to have worked in Wrightington Hospital, the birthplace of joint replacement surgery. I was formerly a consultant joint replacement surgeon in the UK, presently proprietor and MD of SARATHI Specialty Knee and Hip Center. Yeah, so I welcome all of you to this last but not the least talk on our practice in India and Consumer Protection Act 2019. Briefly, I trained in UK in all aspects of orthopedics and trauma. I have a specialist interest in computer-assisted robotic knee hip surgery, patient-specific implant, and a specialist interest in hip and knee revision surgery, for which I did a fellowship with Mr. Evert and Mr. Anthony Ward, and along with Mr. Mehool Acharya in Even Orthopaedic Center, Bristol. My other passion is for septic revision, infected revision. My center does provide quarterly referral service for India for these difficult surgeries and the challenging patients, really. I work with Professor Gerke and Endoclinic, who's a very well-known authority on infected revisions in the world, in Hamburg, Germany. My objective of Meet the Master course is to push the boundaries of our understanding in arthroplasty, really. And one such thing happened last year, same time as well, when we had the hospital hip detective, Professor Alistair Hart, who was here, and there was an exciting debate with Mr. Evert on the 3D printing in orthopedics. And I think I got fantastic reviews from all the senior surgeons about that particular debate, really. Yeah, so before I start, I would like to express my gratefulness to all my trainers, starting with Dr. Jonathan Keenan, where I did my first computer-assisted surgery fellowship in remote teaching hospitals. This is run by John's my daughter, actually, in because I loved knees at that time, so she did it with the revision implant, and Sachin Tendulkar's body being sort of morphed into my head, really. And this was a second fellowship with Mr. Evert Smith and Mr. Anthony Ward. So Evert did a fantastic talk this morning about robotics in hip surgery. This was the first Spire approach that Evert did in India. This was at All India Institute of Medical Sciences, New Delhi, on the left-hand side. And this is the inaugural Meet the Masters course in Bangalore, Lee Meridian, where we am flanked with by my teachers and my friends. This is my third fellowship with Prof. Garka in Endoclinic Septic Revision Fellowship. Prof. Garka is well known in India. It doesn't need much introduction, really. I'm very grateful to Dr. Richard Parkinson, my mentor for knee surgery. And he was the president of British Knee Society from 2014 to 16, voted top 10 best knee replacement surgeons in the UK. Also sort of did few sessions with Dr. Frederick Lord. He's a pioneer of anterior approach to hip. And in 2013, he had done more than 4,000 cases. Incredible surgeon in in Paris, in Tours, really. And this is Frederick Lord, and this is his cadaveric workshop there. And I also followed all the Zimmer surgeons. It was an incredible fortune to meet Prof. Wayne Proposky in Nottingham. We all know about Prof. Proposky. All the acetabular defects is based on his classification, and also a passion to and fantastic opportunity to watch Dr. Lawrence O'Hara and Jeremy Latham, big Zimmer surgeons. Lawrence is in Bournemouth, and Jeremy, I met one of the meetings, good friend of Evert. And coming to today's topic, complex surgeries in India, knee and hip surgeries and Consumer Protection Act 2019. What is CPA? It is Consumer Protection Act, and this was revised and it became an act into full force in 2019 during the pandemic. Before 1986, doctors were exempted from consumer protection laws in India. The Indian courts realized that since independence, the number of doctors punished for malpractice by the medical regulatory authorities in India were in single digits. So court decided to bring Indian doctors under the ambit of Consumer Protection Act. So what is CPA 2019 versus doctors and hospitals? Instead of a cap on the compensation, there is now expected to be an increase in the number of cases filed for compensation due to the ease of filing. Now patients can do e-filing or through video conference. The district commission is going to decide almost 100% of the cases. And if the doctor or a hospital doesn't respond within 24 days, then it's deemed to be admissible. The guilt is deemed to be admissible. Basically, in simple terms, patient can sue from their home. No fee for service paid up to 5 lakhs. They don't have shell down money for if the total bill is around 5 lakhs. And there's no penalty for frivolous cases. They can make some false allegation as well. And earlier there was a penalty, but that penalty has been removed now in this law. So exorbitant compensation being awarded, by increasing pecuniary jurisdiction of the Consumer Commission, the Act de facto accepts that compensation up to and above 10 crores can be and should be asked for and awarded. What happens is in case of a doctor who is involved in litigation dies, the order 10.10.2 says that the death of a plaintiff or defendant shall not cause a suit to abate if the right to sue survives. That means the patients can now attach the property or the estate of the doctor and come on to the families of the doctor. So it's really unfortunate. Coming to knee and hip orthopedics, I know many junior doctors are also part of this meeting, and I know some of my fellows have joined as well, both from UK and from India. So I'm going to, the first two talks were master talks, fantastic futuristic talks. So I'll keep this a little bit simple. Apologies to the seniors. Arthritis affects around 20 million patients in India. So around 1 in 5 Indians are affected with arthritis. And, 1 in 4 of them will need some kind of surgical intervention in their lifetime. The COVID, particularly the second wave, has proved that there's a big skill shortage in India. I think before the COVID, a lot of doctors group were discussing too many doctors, there's too much competition, cutthroat competition, rat race, and all this kind of thing. So what COVID second wave did was it just put a mirror in front of all the Indian healthcare. It showed that there are no doctors in India. And this shortage, forces every trained and untrained surgeon to get involved in hip replacement surgery. In a computer-assisted or robotic surgery, there's a saying that garbage in is garbage out. So, and one of the basic tenets in arthroplasty is that if you fail to prepare for surgery, you prepare to fail during surgery. So this is the outcome of an untrained person doing an arthroplasty. This is immediate post-op picture of a central fracture dislocation following a hip replacement surgery. Who wants this? The patient doesn't want it. The surgeon doesn't want it. The hospital definitely doesn't want this. Coming to knee arthritis, as we realized from Mr. Acharya's talk, the knee is a complex three-dimensional hinge. These are the standard indications for knee replacement surgery. These are the types of knee replacement surgery. It could be a half knee replacement that's called, that is medial uni, lateral uni, patellofemoral replacement, or a total knee replacements. Many common myths and practice. When I moved from UK to India, I had to face some of these myths really. So one of the myths I had to face was that eyeballing was better than computer navigation or robotics. And now with the robotics and with its 1 millimeter accuracy, I think this issue is largely settled. There's no debate about that. And second issue was one size fits all, while the truth is that every knee is different, and Professor Acharya clearly mentioned that we need to go to a personalized alignment, and that's the way the future is going really. So one size can't really fit all. And looking at an X-ray and just doing a total knee replacement in 2021 means that giving a two-dimensional solution to a knee, which is basically a three-dimensional problem. And other thing is that you can always plan surgery on the table. I always tell my juniors, operation table is a place to execute surgery, never to plan for the surgery. So other myth is that anybody can do a knee or hip replacement, and I was really surprised that this came from the hospital management, and particularly some of the senior management. It came. I was gobsmacked, and I did a survey, in the UK on my trainees, my registrars, and that survey also showed that my registrars in UK also felt that anybody can do a knee replacement surgery. And I asked them why, and they said, "Oh, Mr. Srikanth, what's so great about that? Just open the knee and put the jigs, cut the bones, patch the implant in, and close up the wound, and big deal. Surgery is done. Bobby Srikanth." And let us explore if this concept, what these two groups had, is really true. This is Dr. John Eboniser, the father of knee replacement surgery at Hospital for Specialist Surgery, and he said that knee replacement is a soft tissue operation with some bony cuts. And he said this in 1973, and in 2021 we are still debating what he said several decades ago. So why did he say this? Why did he not tell like my registrar or like hospital management? That's because like Professor Acharya showed, he knew the role of the ligaments. So this is the role of the ligaments, and we dealt in detail in the last session really. And we have this 6 degrees of freedom of the knee. And if you do a standard 3 cuts to do a knee replacement, if you add the two combination of permutation and combination, there are 215 ways in which even a senior surgeon can get a knee replacement wrong. So I've answered the question to the common myth, So clear no if you have patients interested in your heart. Primum non nocere, that is the first principle of ethics, that is first to no harm. If in a doubt asked, there is no shame in it. A proper training and experience is a must. So these modern concepts like navigation, patient-specific implants, 3D augmented knee surgery, and robotics are coming. We know this guy, we know why he is the best, because we can measure what he has done. What are the limitations to the human eye? Eyeballing can't differentiate more than 10 degrees of change in various valgus angulation. We know that more than 6 degrees change in various valgus alignment can lead to catastrophic failure of the knee replacement surgery. We don't want a bad day in office to affect the outcome of our patient surgery. We want to minimize surgeon's error when so many factors are at play, some known and many unknown, like role of ligaments. And 1 millimeter accuracy is humanly impossible. And alignment, I learned a couple of new alignments today in the presentation. This alignment types versus the balance issue is still not resolved in 2021. So there is a definite need for these advanced technologies. I started my robotics in Bangalore from the beginning of this year. Definitely it gives 1 millimeter accuracy to the bone cuts, and the bone is cut taking the 6 degrees of freedom into account. There's definitely less soft tissue dissection, and I'm really surprised myself, because every time I want to do medial release, I'm not doing much as I was doing before, and each surgery, the medial release is coming down and down. And other surprise is that blood loss, I have stopped transfusing for all my robotics now. I used to transfuse regularly for the non-robotic, and this is really surprising. I really need to look into the data and see if this translates into some paper eventually. So this is, because of these things, early rehabilitation is possible. Early straight leg raise is possible, and possibly early discharge. This is the picture of my first robotic graph on the left-hand side after implantation. You can see there the blue boxes and then the orange boxes showing various valgus. And from 0 to 130 degrees, it's just 1 millimeter opening on both the sides after the final implantation is put, So, Dr. Kaper, who was the creator of this robot, even would be proud of such a flat line, and this was a perfect soft tissue balance in the whole range from 0 to 130 degrees knee bending, really. And I think for me, this is the first time that there is an objective evidence of soft tissue balance. Earlier, I used to say my knee is balanced or other person's knee is more balanced, or he would say his knee is balanced or my knee is balanced. But now we've got to prove the objective evidence, really. And hence, this is the future. This is another post-operative X-rays done using similar technology last week. And this is the patient, the first surgery patient who was able to lift the leg and bend the knee, immediate post-surgery in the recovery, a couple of hours later. Coming to complex knee and hip surgery, my Indian experience, the first case is a 60-year-old lady, 120 kg diabetic. Mr. Evert Smith talked about the challenges that he faced with the obese patient with 150 kgs, and these are not easy. They are, a nightmare really. And this lady was operated by the top 2 arthroplasty surgeon of my city, Bangalore, and the state, Karnataka. Unfortunately, the knee got infected. The primary surgeon was a senior surgeon. He went after, did 5 more surgeries to resolve this, but he was not successful and he gave up. And he had to leave her with no joint in the knee, what we call excision arthroplasty. So quite naturally, this lady was bedridden, and her daughter stays near to my center. She came to me 2 years after the last procedure, and she said, "Dr. Srikanth, my mom is disabled. I have got a disabled sister. I'm unable to really, look after them. Can you really help me?" So I said, "Yes. This is my training in Germany and UK. Let me see what I can do." So this is how she came to me on the left-hand side with a complex primary knee replacement. This is what was done in the initial surgery, and this is how she came to me in the right-hand side with the excision arthroplasty. The issues that she had was obesity, diabetes mellitus. She had 5 failed surgeries before. She had multiple scars. You can see I have marked all the scars with the blue pen. There are at least 3 scars visible there. And then in the last surgery, the primary surgeon was not able to close the wound. So he called his plastic surgeon to bail him out. So he came and did a gastrocnemius flap. So I knew that if I get into trouble in this surgery, I will have only one head of the gastrocnemius left to bail me out, really. And there was gross shortening and inch shortening. I'm demonstrating this with my hand at the bottom. There's an inch shortening. She needed a bariatric type table and a bold anesthetist to take her on. So we planned and I aspirated the knee, grew E. coli, we got the antibiogram, planned revision in 2 states, put the antibiotic loaded cement spacer there. And, ESR CRP came back to normal in 8 weeks' time. I did a repeat aspiration, it was clear. And the issues for second stage was which hospital. I needed a good ICU backup. The teamwork was a combined orthopedic and plastic surgical teamwork. I had to get clearance from a senior physician, nephrologist, cardiologist, vascular surgeon, and a senior anesthetist. Because she had issues with each of them. She was diabetic. She needed a senior physician's opinion. She had abnormal urea creatine, little borderline off, so the nephrologist got involved. She had some cardiac issues. The cardiologist got involved. My anesthetist said, "Oh, Sri, I really want you to get checked with the vascular surgeon. There's some vascular issues in a previous surgery." So I had to send all the Doppler, everything to my friend who is a top vascular surgeon for Karnataka. And he said, "Mr. Srikanth, I've seen other senior surgeons doing this. It's perfectly fine. Go ahead. Nothing will be a problem." So then, I could go ahead. So the challenges during surgery was the type of anesthesia. After so much blocks, one of the junior consultants, 2 of them were giving the anesthesia with the spinal block and the patient lying down. The spinal went up to the diaphragm and she almost stopped breathing. I ran to the senior anesthetist and said, "Sir, come and help." So he came running to a theater, immediately converted that into LMA and a short kind of a GA kind of thing. And, we could proceed further on. So it was a prolonged surgery, and it did last for 4.5 to 5 hours. I tell my juniors that, after 2 or 3 hours time, one can run out of steam in these complex surgeries. So unless you're trained, you should really not get into these kinds of surgeries. There was massive fluid shift during surgery. Quite rightly, she spent 24 hours in ICU and got discharged. The quality of quadriceps was an issue. Despite rectus snip, she had a previous quadriceps repair. So there were some minor tests which had to repair perioperatively. So after many more challenges, I put a RHK, and This is her 2.5 years after she was able to say, oh, doctors operate for money, but this gives me more satisfaction than the money that the patient is able to give, really, that she is ambulant and not dependent on her relatives. This is a complex case too, the osteoporotic conundrum. A 62-year-old lady, again, not walked for 2 years, and she was literally carried by her son to my center. I still remember in the hand she was carried. She was seen by a very respected senior professor of orthopedics in Bangalore, who is very well known to us in our GOSI group as well. And he had apparently told the patient, God help you. And look at the X-ray there, complete pathological dislocation, how she came. And one of the surgeons had aspirated the knee and not grown anything. She literally came with 90 degrees fixed flexion deformity. An MRI done showed a complete destruction of the joint, ACL, PCL, pus in the knee, pus in trochanter, pus in ankle. So I really had to plan a stage revision for her. I did an open reduction of the knee and a radical debridement, and sent a lot of samples. I used flexible trauma reamers, went up with the peroxide and betadine up to the trochanter, up to the ankle really. And I put a antibiotic loaded cement static spacer. And I sent literally all the investigations in India. It all went to Hyderabad as well. And all the investigation came back negative despite frank pus in the knee. So I was really flummoxed. Thanks to my training, I had sent samples for histology to my friend, Dr. Prasad, histopathologist. He called me next day. He said, Srikanth, this is classic caseating granuloma, it's tuberculosis. So he saved the day for me. He bailed me out really. And, I could start her on ATT. Quality of the bone was paper thin. And, she was not a very compliant patient. The issue was, I asked her to non-weight bear, but she did partial weight bearing, and that led to kind of supracondylar fracture. And not very rich as well. They said, Dr. Srikanth, don't put RHK, will cost us 2 to 3 lakhs, or if your striker fusion nail cost 2 lakhs, it's 2,000 pounds. They couldn't afford it. So I had to really think out of the box for this patient. So they did offer a knee fusion. And, this is the nail, which is around 2,000 pounds here in India. So when standard companies in India couldn't help me, I had to call up a distributor in Gujarat. So they think laterally in Gujarat. And I sent him a templated X-ray, and he really customized this nail for this patient, and for a cheap price as well. And what we call now under Prime Minister Modi is Atmanirbhar nail really. So I could bypass the supracondylar fracture as you see there, and also lock it proximally distally with the functional position. And with the ATT, she went on to heal and fuse in 6 months' time, and she was able to walk. Coming to challenging hip surgeries, I want to talk about hip arthroscopy in delaying THR and patient-specific and custom-made hip replacement. But all these things will be talked in the BHAC 2021 in detail. So let's listen there. And spine, pelvis, hip axis, Evert has dealt masterly about that in the first presentation today. So this was a 35-year-old patient who was a IT professional, that is, from the software profession in India, computer engineer. He was son of a pediatrician, just to add to the pressure really. He had an RTA, and he had a left central fracture dislocation, probably a bicolumnar fracture. So he had a ORIF done, and an anterior column plate and a posterior column screw put, and he had a quadrilateral plate plated as well. And so apparently, as per the patient and her mom, who's a doctor, he developed a sciatic nerve palsy during surgery. And it took nearly 18 months for this palsy to recover really. So he met me in 2018, 2 years after the index surgery. So when I examined him, he had around 2 inches shortening of the left leg. He had jog of movements in the left hip, because of protrusio. His abductor strength was around 4+ out of 5, not because of neurology, because he had not used the hip so much because of the protrusio. EHL, EDL, 5 out of 5, sensation was normal. So nerve recovery was good from sciatic nerve. And so he had metalwork, and the quadrilateral plate had screws which was projecting into the acetabulum by 3 to 4 millimeters. So I had to plan this in 2 stages. So first surgery was to remove the plate. So, I did this in a French hospital who was got interest in pelviacetabular surgery, and, vascularity was okay pre-op. And we did consult a vascular surgeon. I called my favorite vascular surgeon, the top man in Karnataka. He said, Dr. Srikanth, I'm a director of a big unit in Bangalore, so I can advise you, but I'm operating at that time, I can't come. So my friend also had called, his vascular surgeon, who had said he will come definitely if we run into trouble. So we had 2 units cross-matched and 2 units grouped and saved. So, we basically went through a rear approach, and then we removed all the screws from the anterior column plate. And, despite doing that and checking it on the image intensifier, the plate would not budge. I think there was a thin layer of bone over the plate, it would not budge. So we both had a discussion. My colleague was around 6-7 years senior to me, and he said, Srikanth, let's twist the plate a little bit and pull it out. So I was near the lateral window, so I just took a pliers and then mildly twisted and got the plate out. It came out nicely without much struggle. But the moment I took the plate out in my hand, it started pouring blood into the pelvis, and there was a vascular injury. So basically, we put a large mop on the wound into the pelvis. I informed the anesthetist to start fluids, blood, and vasopressors. We called the vascular surgeon. Both the vascular surgeon's name was on the board. And my friend, as I said, is a senior surgeon. I've never seen him sweat. It was his hospital, and I could see sweat dripping down his head, as to what might happen really. So anyway, the vascular surgeon came promptly within 15 minutes. He used his typical loops, and it showed that it was not an external iliac artery damage, but it was a vein damage with around 6 mm rent. So he put fine sutures and repaired it, and there was no further bleed. And as the plate didn't have any infective features around it, so I abandoned the concept of removing the quadrilateral plate and the posterior column screw. So the definitive surgery, I explained this to the patient and to the mom, and he recovered well. Mom, being a doctor, understood what was going on really. And 12 weeks later, they came back to me for the second surgery, planned surgery. As I mentioned, the issue was a quadrilateral plate. The screws were into the acetabular floor by around 2 to 3 mm really. And I templated this patient. I planned for surgery. I ordered diamond cutting bird to chew up these screws entering into the acetabulum. And I did a posterior approach, in situ neck cut to deal with the protrusio, dislocated the hip, and got the patient's femoral head, got to 8 and 9 mm protons with a nibbler from the femoral head. I impacted this bone to the floor. I reverse reamed, and I used an uncemented link up with 2 good screws in a strong bone. I put a ceramic and ceramic liner, and with a large ceramic head. And I used the Exeter stem for a perfect antiversion and stability. I gained around 1 cm of length, but I was not bold to go beyond because already had sciatic nerve injury. So post-op sciatic nerve was okay, and there was no further vascular injury. So I was quite relieved. So the outcome following this, the patient sent me his post-operative physiotherapy, a week following his discharge. He's quite happy with the outcome really. In fact, I met him just last weekend in a shopping mall in Jayanagar near Maya's. Dr. John and Amar would know that. He normally travels with his wife and mom, but he was walking independently and planning to go for a Goa trip with his friends for this Diwali really. So this is how he's sort of walked a week following surgery. So it's always pleasing to see when things go right for our patients really. I think this hip spine axis, Mr. Smith has dealt with it in detail. And the other word of caution, this is a very popular stem in India, the uncemented hip. This is a case done in UK actually. Uncemented stem usually goes where it wants to go. The left side has got a varus neck, which the surgeon missed, that led to limb lengthening on the right side. And then the physiotherapist told the patient, made a comment that, the right leg is long. That added to the patient, and the patient successfully litigated against the surgeon in the UK. So last Meet the Masters course, there was a fantastic debate between Professor Hart and Mr. Smith. And Professor Alistair Hart said that after all this 3D robotic work, he feels that a cemented stem is an option for a hip replacement surgery, not an uncemented stem. So that was very interesting really to listen to that last year's talk. So what are the solutions really for these problems? As Professor Hart says, probably a cemented hip or a cemented stem. And OPS, which we're going to discuss in the Bristol Hip Orthoplasty meeting, is other things is very useful. Robotics, which Mr. Smith discussed this morning, and a custom hip symbiotic hip, which we are going to again discuss in the BHAC. So many surgeons ask me, sir, can I get a chance to work in the UK? And what UK is really looking for is a knowledge, skill, and attitude. Okay, this was a surgery done not far from my center by one of the doctors, and a fairly skilled surgeon really. And he did a primary knee replacement. And after the knee replacement, unfortunately, after 6 to 8 weeks, knee got infected. So it was beyond 8 weeks. So he decided that he would do a radical debridement. So he did a radical debridement. So after radical debridement, he put a revision prosthesis, as you see on the left-hand side. But he cemented both the stems in the femur and the tibia. And to his bad luck, this knee also got infected. Now he was in a suit. So what to do now? India doesn't have an Oscar, and what do you do? So he was literally forced to split the femur and the tibia to take the implant out, the stem out, and the cement out in total to eradicate infection. So, just cementing around the metaphysis and not cementing the stem would have, bailed out of the situation. You could have put another RHK type of implant and then, went for a two-stage revision and maintained the patient's knee movement really. But here he was forced to do a knee fusion really. So how to avoid being in the cesspool? Follow the guidelines and protocols and standard operating procedures, even if made by your own institution, to the hilt. Have an algorithmic approach to any problem. Law expects you to keep your knowledge up to date. Lack of common and widely available knowledge, whether even it's in Google, certainly weakens your defense on the grounds of error of judgment. When in doubt, seek a second opinion, and you need to document everything. So, brief thing on Bolam versus Bolito and Montgomery. Those junior doctors who don't know, Bolam was a patient in the UK. This was a pre-anesthetic sedation kind of days where he had a epilepsy or fits. He was given ECT, electroconvulsive therapy, without sedation, without restraining him. As a result of that, he sustained bilateral hip fractures. So the law came in UK that, if a reasonable body of doctors, treat it in a particular way, that's how a patient should be treated. If somebody is deviating from that, then he is found to be medically negligent. This is Bolam's law. Even today, the Indian Supreme Court accepts the Bolam's law, but Bolito is also sort of coming in where the Bolam's law is suspected to logical analysis of the lawyers and the judge. There are two cases in India where the Bolito was applied in the classic Samira Kohli versus Prabha Manchandani case. Every doctor in India has to read this. A big compensation is paid out, in this case. And coming to Montgomery versus Lancashire, in this case, the perspective of the informed consent, by upholding patient's decision to know what they want and not the physician's decision to do what he wants to do really. So we need to really ask what the patient wants really, and that's where law probably may be going. So in UK already the Montgomery is used, I think, but India, fortunately, we're still in Bolam, but with some application of Bolito. So how to choose the best option for patient without falling foul of the law? Defined standard of care should be adhered to. Guidelines should be the guide for us. We need to recognize our limitation. This is very, very important. I tell my juniors, never bite more than what you can chew. Competence in doing the procedure is a must, and treatment should be the most important thing to decide. And don't hesitate to refer. So if you're in doubt, ask, explain, and document everything that you do. Like Dr. Alexander Artemiou said, there are 4 phases a surgeon undergoes when faced with a difficult surgery or extreme hemorrhage. The first phase is, why did I get involved in the surgery? Second is, why did I become a surgeon? Third is, why did I become a doctor? Then the 4th stage is, why was I born? So let us not get into this stage really. So my take-home message is Consumer Protection Act 2019 is a draconian law. We just lost a court case in Bombay High Court 2 days ago. So this law is here to stay. Get it right first time. It is grift is an important and evolving concept in orthoplasty. The insurers, the patients, and legal fraternity will demand this more from us in the future. Revision knee hip replacement is a complex area of work. Can take from 2 to 6 hours. One needs patience, resilience, passion, teamwork, and experience to do this. And as I mentioned, we can easily run out of steam in 2 to 3 hours time. So definitely not for the naive. And the training is a must to perform these complex surgeries to an acceptable standard. I'm told that Mr. Steve Beveran, one of the biggest orthoplasty surgeons in UK, does primaries and refers all revisions to revision surgeons. And there's no shame in this when a big guy is doing it like that. And UK, understand all infected revisions are referred by revision surgeons to consultants with special interest in infected revision work. So there's really no place for being a Mako really. The conclusion is, life is short. COVID has drilled that into us. Why take needless risk? Combined work is the need and order of the day. So I tell the younger surgeons, don't perform complex surgeries by looking at YouTube or Boomudi videos. The CPA 2019 is a hostile judicial environment. The medical legal action group is knocking the Supreme Court door to challenge this. And I think we got one chance as doctors in India. And one of the things I realized in the last 7 years in India is that the unity is a big question mark among doctors in India. And there's a lot of apathy. So we need to be united in this case, really fight this. And we need to get out of CPA 2019. It's for the best of our community and for each and every doctor. So when things go wrong, here we'll get roasted, but also jousted professionally and also attacked by the patient's relatives, which is really unfortunate. The popular saying in the UK, when in doubt, refer to appropriate trained specialists or opt for combined work. So let's work together, friends, for less stress and less hassle for ourselves. These are the references for my talk. I really thank you very much for the patient listening, and I seek your support to serve these patients better. So I like this quotation from Aristotle. We are what we do repeatedly. So excellence is therefore not an act, but a habit. So I welcome any questions from the faculty who are present if they have. So if there are no questions from there or from Ortho TV, we will go to the final program, which is a real life surgery from Mr. Mehool Acharya. But before that, Dr. Amarnath has got a little announcement to make about GOSI 2021 meet, which is happening shortly. So I'll just stop sharing the slide, and maybe Amar, if he's free, if he can share his slide, that will be fantastic.
Thank you, Sri. Thanks a lot. Thank you. Folks, I'm inviting each one of you for our virtual conference 2021, GOSICon 2021. And we also have a different way this conference has been designed. There is no didactic lectures. We're going to have case presentations. So when I see this problem in my own practice, how I could attend, how I could, get this challenge resolved so that the patient gets the better outcome. That's the basic thing. So we have faculty from India and abroad, and we have a 3-day conference which has been recognized by the Medical Council of India, and we're going to get 1 CPD point or CME credit hour, 1 point per day or 1 CME hour per day. And it's been very well distributed. One is a trauma, arthritis, spine, and osteoporosis in the elderly. So this is where we are. And then I'm also inviting the faculty here. If you guys are available on these dates, it would be a pleasure to have you folks. And then you guys could share the challenging patients that you had in your practice so that we could learn from our, association. So we have this, and this will be shared with in a group, and we will take it forward from there. Thank you. Thank you.
Thanks, Amar. Thank you for the
Amar, 15th November is the last date. Amar, 15th November is the last date to send the abstracts.
Sure.
Yeah.
Thank you. Thanks so much.
Postgraduate students and other junior doctors to please send their abstracts. Yeah, thank you.
So I know we are running short of time. So if there are no questions for me, we will move on to the last, the real life surgery from Professor Acharya. It's about robotic TKR the bot way. And I should really thank Jason for providing this from the Corin. Thank you very much, Jason. Over to you, Professor Acharya. Thank you.
Hello there. Can you see my screen?
Yes, I can see your thing. Yeah, thank you.
Okay. So essentially, this is a 10-minute video. And what it will do is it'll talk you through the salient steps of performing a robotic surgery by Omni, so the Omnibot. And then what we'll do is we'll open up for questions at the end. So without saying any more, I'll let the video run all the way through, and then we'll ask questions or try and answer questions at the end.
The Omni Robotic Assisted Total Knee System allows you to plan and execute total knee replacement procedures based on the requirements of your patient's anatomy. You can document kinematic results for every patient, perform detailed mapping of the knee with Omni's patented bone morphing technology, and execute your plan with a high level of precision, accuracy, and reproducibility. The Omni system has been designed to accommodate a near limitless combination of surgical techniques. Whether you prefer to cut the femur or tibia first, follow a measured resection philosophy, and/or maintain ligament balance, the system gives you the freedom to customize your profiles for every case. Your workflow can also be adapted intraoperatively. In this short demonstration, we'll showcase a robotically assisted femur-first approach. You'll see how this small, portable workstation allows you to design a plan, virtually performing the surgery on screen before making any cuts. Then execute the plan to achieve unprecedented accuracy and surgical results. Because all surgical planning is done in real time and based on the patient's actual measured anatomical data, there are no preoperative scans required and no need for custom-made cutting blocks. Now, let's head to the OR. Small and portable, the Omni robotic workstation can be easily positioned in a crowded OR, with its overhead camera typically located within 5 to 8 feet of the operative knee. Arrays facing the camera are mounted medially on the patient's femur and tibia. Setup for the robotic cutting guide begins by mounting the femoral arrays with 2 screws inserted into the medial femoral condyle using the pin placement guide. The tibia array is then attached with 2 screws inserted through the skin. The arrays are placed on screw fixations and calibrated to sync with the camera. This attachment creates a secure and stable fixation platform for the robotic cutting guide. The next step is to identify critical anatomical landmarks. Simply follow on-screen prompts and touch the P pointer to each landmark. So, how does the system optimize implant fit? It includes patented bone morphing technology, which allows you to quickly create a detailed, accurate 3D digital model of the knee. Bone morphing is intuitive to use. Simply run the pointer across the femoral surface as shown. The system allows you to rapidly acquire data points, and it alerts you if more points are needed. You can also perform light bone morphing of the tibia. The system acquires just enough data points to provide sufficient visualization of the tibia. And it generates real-time, patient-specific data that can be used to determine resection, implant placement, and to make decisions about soft tissue balancing. We all know success in total knee arthroplasty is critically dependent upon implant alignment. As shown in this preoperative assessment, a quantitative analysis of the knee kinematics displays potential range of motion and varus valgus stability. Now let's take a look at how this robotic-assisted system supports femoral planning. The system is designed to accommodate the apex knee with all sizes and models pre-programmed into the software. Based on these configurations and your preferences, the system calculates implant sizing and alignment, which you can fine-tune. This enables you to plan and visualize those planned bone resections before cuts are made. This digital plan is used to determine the position of the cutting guides. First, the robotic cutting guide is placed into the femoral fixation base and fixed into proper alignment. After the system performs a calibration, the cutting guide is positioned to make the first distal cut. The surgeon is always in full control and can make any final adjustments necessary before performing the bone resections. As you carry out bone resections, the system also senses if there is too much pressure on the guide and will resist against inaccuracy while notifying you with an audible tone. After each resection has been completed, cuts are validated using the G pointer. If necessary, small adjustments, as little as 1 millimeter in thickness, can be made. After confirming the distal cut, the cutting guide automatically advances to the next cutting position. The following resections are carried out with equal precision. Again, every cut can be validated to ensure accuracy. The robotic cutting guide, integrated with the system, replaces the need to manually position and pin conventional cutting jigs, which can introduce errors in alignment and implant fit. Because the system automates placement of each cut according to your plan, you can feel confident knowing you'll achieve the most accurate results for all femoral resections. Next, we'll show you how easily you can reshape the tibia. First, attach the adjustable cutting guide into position using the 3 pins as shown. Then position the block by turning the 3 color-coded knobs. System prompts specify the direction and precise amount of rotation for each knob. The system displays a green line to indicate the guide is properly aligned. Once the guide is positioned, you can perform the tibia resection. Then verify the cut with the G reference guide. A green line on screen indicates the cut was executed per your plan. Finally, remove the cutting guide in preparation for trialing and final alignment. Trial components are used per standard surgical protocol. With trials in place, the system displays the alignment of the knee through a full range of flexion and extension. This enables you to evaluate that the plan has been achieved as desired and allows for fine-tuning, including soft tissue balancing. Once implants are in place, you can verify and quantify results on screen with the system's post-operative kinematics, including range of motion and varus valgus constraints, to ensure that your plan was properly executed. The system also allows you to directly compare pre- and post-operative kinematics to confirm proper alignment. Plus, you can now share these documented results with patients to help them visualize their alignment post-surgery and better understand how neutral alignment can ultimately improve their knee joint functionality to relieve pain. Execute your surgical plan with robotic precision. The quality of total knee replacement is heavily dependent upon a plan that meets the anatomical needs of the patient, and that execution of the plan is made with precision and accuracy. The Omni Robotic Assisted System, exclusive to the Apex knee, helps you meet this objective in each and every procedure.
Great. So just stop that. Very good. Okay, so great. So we'll open up the floor to any questions that people might have. So that was the Omni Robotic knee replacement. One thing it didn't show was the soft tissue balance spot and the tensioner. What I tend to do is I would cut the tibia first and then put the tensioner in, and then that would give me an idea of the pre-op kinematics, and it would give me an idea of where I needed to place my distal femoral cut and my posterior cut and align my femur according to that. So that's the way I would do it if I was using the soft tissue tensioner. But that gives the video gives you an idea of the precision and the mechanics of the robotic replacement.
Thanks, Mez. That was a fantastic video. Any questions from Evert is here? Dr. Deepak from Ahmedabad. Any questions, sir, for Mez?
So, Mez. Hello, Mez.
Hi.
You're talking about navigation rather than robotics, in essence.
Yeah, in navigation, you're looking at a screen and you're still moving all the saws, the hammers, all of that. Whereas with this, yes, so it is active because you're in control of it, but the robotic side of it is the fact that you have a jig which the robot manipulates into the accurate position, so that you can make your cuts. But you're right; it is an active process.
Well, I mean, I think your answer is important because I think it's a kind of a smart combination, isn't it?
It's a smart combination, but the beauty of this is the incorporation of the soft tissue balancing, and bringing that together is fantastic. So being able to do both with one instrument, hopefully, it'll be confirmed with clinical outcome papers long term. But I think if they do show promising results, then that's a game changer.
Dr. Deepak, Dr. Amar, any questions you got?
Yeah, I think going back in time, I mean, when Mez was talking about the kinematics, I mean, it takes me back to my training 25 years ago, the kinematic knee, the kinemax, and the rotating platforms, and oh my God, I mean, today we are talking about Omni robot. I mean, it's fantastic. I mean, we have literally, traveled the other edge of the planet in that true sense of the time, what was done and what we can do now. And then obviously, like what Evert said, it is more of a navigation assisted with, and I really like the way the robotic alignments does on its own for the special cut. It's already planned, that's fantastic. My question here was probably, do we need to use the implant given by the Omni, or do we have our own thing that can be done, or is it customized? How do we go about it?
Yeah, so that's a great question, and we've got Jason from Inemax here who'll be representing the Omni as well, so he'll be able to say something after I have. But from my understanding, it can only be used with the Omni or the Corin type implants, and the reason for that is because all the information has been loaded up onto the system for that. I'd have to refer to Jason to see whether, if you had a process where other information from other implants was uploaded, whether you could potentially use it for a whole array of different implants. Jason.
That's been one of the big questions, Doc, is how widely available is the technology to all of the other implants. And what we're finding at the moment is a lot of the companies do not wish to share a lot of their patented information on their products with us to allow us to load it onto the system. We do have a few smaller orthopedic companies in America that are very happy to share that information. And hopefully in the next 6 months to a year, this platform should be able to allow you to access about 4 or 5 different companies. But currently at the moment, it's tied up to the current knee systems.
And what about the availability in India?
At the moment, we are just getting all of our certification done. We're hoping that we should be allowed in with the robot December, January. That's the time frame that we've currently got for it.
And would you be able to get our young surgeons to be trained? And how do we go about it? Probably I'll be in touch with you, and then probably we could take it forward and see where, we can help.
No, for sure. That's something that we've been looking at. I've been talking to a few surgeons about it, and the key about this is there's got to be a proper training regimen to it. The current numbers we've got is it takes around 7 to 12 cases for the surgeon to become completely comfortable with the change in the operation. And that's accompanied with around another 25 to 30 minutes extended time for your total knee. But after 15 to 20, that comes down to your standard time. So again, once you are more familiar with the process and the technology, it'll come down to what you would normally take for a total knee. That's I think been the one take home from our system, is that with the modality and how we've structured the systems, some is autoclavable, and you can have 2 or 3 of the Omni bots being autoclaved. You can have one TV system that you can move between theaters. So for us, that was our main objective, was finding a system that was very mobile, and that instead of doing 3 total knees in a day, you could go back to doing your 5 to 7.
That's wonderful, great. I think Sri, we should look into probably, and once they get the licensing in 2022,
this
probably,
is the future.
Yeah.
So thanks, Jason. Thanks for that.
Thank you.
Mes, I've got a few questions for you from both the talks, not just the last video presentation. The Stryker group, particularly ECOF's work, they talk a lot about this a trans-cylindrical axis and as a sort of solution for the mid flexion instability. So what is your thoughts on that?
So you mean a single radius curvature? Yeah. And I'm a big fan of that. I think my standard knee that I use is a Stryker knee, is a triathlon knee, and that's what I use as a standard non-navigated, non-robotic knee, and that's a single radius of curvature. And actually, both clinical reassurance, but also intraoperative feedback, testing them in that mid-flexion position or graduated flexion, I think it feels pretty stable, both medially and laterally. So I think I'm in favor of a single radius of curvature. I believe in it.
Thank you. And we've got these designs which are medial pivot designs and lateral pivot designs. I think the DJO has got a lateral pivot design. So what is the effect of these designs on the forgotten joint score or the forgotten knee really? Do they have an impact on the forgotten knee?
Yeah, that's a good question. So the forgotten joint score, I wouldn't be sure of the exact differences between that and a standard knee, but I think a lot of the studies do show that the short term probably there is some difference between the medial pivot or the lateral pivot, as you say, and I think all of that is based on, I suppose, the contact stresses through different points of flexion and extension, and that last bit of rotation. So I think that's key. And I think there might be more than one way of doing it. I agree. But I think the whole aim of it is to try and make sure that throughout that arc of flexion and extension, you're balanced throughout. And if you can achieve that, there might be different ways of doing it, but as long as you can achieve that, then I think you're getting closer towards getting towards that forgotten knee.
What about what Prof. Bellam says about having a differential poly in the tibia as a way to get a perfect balance? Do you sort of believe in that concept, or what's your thoughts on that?
So I've seen it, and I think it's Persona, Zimmer Biomet, the Persona knee.
Journey
knee has it, and the new Persona knee also has it. And I've seen it. I haven't actually used it, and it seems quite neat. It seems like a good thing, but I don't know the evidence behind it because I haven't used it myself, and I don't have the actual hands-on experience with it, so I don't know. But I think all these little changes. I mean, you've got to be very careful because we've got Evert here on the ODEP panel, and it's really important to understand that any little change that you'll make to a particular implant or technique could affect your results. And we've talked about NJR results in the long term, etc. And it's just important to bear that in mind that if you're making any change into your own practice, just be aware that those changes might bring you as an outlier. So any calculated changes, just beware of them.
Okay, thank you. So I think it's already 10:30 here in India on a Saturday evening. So I think I'll ask Amar to give a sort of vote of thanks. And if there are no further questions from Ortho TV and other panelists, we will wind this up really. Yeah, Amar, over to you.
Hey, great, Sri, good going. I think, gone are the days where we could probably plan this and plan that, but today it's amazing the way we are heading. And probably, I think, like what Evert was talking about from confusion.com, I think it's going to be the big way now. Where am I going to be in? How do I fit it in? And then you coming in with the CPA in India, are we doing the right way, the wrong way, the CPA way? Are we doing the medical, or are we doing the legal medicine? Are we practicing what? Oh gosh. I think there's going to be a lot of things that one needs to answer that. And to tell you frankly, I think we thought we are going to be bionic. Forget being bionic, and we are getting humanoids. And probably we're getting onto the Robodoc now. So that is the biggest thing. It is crazy. It's crazy, I think. And the vision, what Evert was talking about now, the 20, 30 years now, it's going to be the robotic. It's just going to be the Robodoc doing the work. And we don't need to sit there probably. I don't know. It's good to have the AI, but where will the AI take us to? Or is it still the surgeon? Yes, I think surgeon still has to have the soft tissue. It is the surgery, like what you did mention about, going back in 70s to Ansel Clinic. So naturally, it is still going to be that. With few cuts on the bone, and it is a soft tissue surgery, being the hip or the knee. And the kind of things what Evert was talking about and Mez was talking about is unimaginable. I mean, we need to be very clear, right from the stance to the position to the pelvic and spine axis, extremely important positioning of your cup and to the implant what you choose and all that. And definitely 3D printing is the future. There are a lot of work which is being done in India, and I think it's going to be a positive microchip. We're going to have it, and it's going to monitor. Definitely, no doubt about it. And India recently, I think 3 weeks ago, under the Prime Minister Modi, has launched the digital health data for every citizen in the country. It's going to be a massive 1.3 billion. Unimaginable data that's going to be compiled, and it's going to be there for us to access it. It's crazy, So with all this, you have brought in a fantastic group of array of people that we are having it, and the future of the robotics and the hip and knee surgeries where we are heading, from having it to customizable implants to having the robotic assisted and taking it forward. And I think we will definitely be in touch with you, Jason, when once you have your licensing up in 2022, and then definitely we're going to have the Asia Pacific component coming into picture here for us in India. So that is one thing. And I thank Evert, Mez, Jason, Ashok Sham, John, who has been a part of our group. I don't know whether John is still there to probably he can put in a word or two. I think Deepak has left. I thank everyone, Supriya. You've been there right from the time that we are on, and then hope you had some break in between to munch or two. John, you want to have, John, you're there?
So before John comes in.
Yes, Amar,
Please, sir.
Yeah,
Fantastic.
I am there. I have texted messages also. I have congratulated Srikanth for an excellent academic meet and also for his excellent talk and his amazing work on re-revision arthroplasties. Really stupendous job he has done. And even Mez and Evert delivered excellent talks. And it was really illuminating to know the various technologies that has come into surgeries now. And it was really a great session. I also thank Ashok Sham for creating such a wonderful platform for academic meetings. Indeed, he has taken this academic meeting to the nooks and corners of the world now. So it's a stupendous achievement. Thank you, Amarnath, for being an excellent moderator, host, and for also getting the CME credit points. Thank you. Hope I will be there with Srikanth in all his programs, and we enjoy collaborating with him. Thank you so much, and good night to all.
Yeah, and then one last word, sorry, Sri. I think, as you rightly put on the screen, I should definitely thank David for Clockwork UK to have it, relayed there, and then we will definitely have a better, bigger, and future relationship to take it forward too.
So just a word from SSOC. I really take this opportunity to thank all the distinguished faculty for educating us today, and particularly coming on a Saturday and helping us. Big thanks to Evert and big thanks to Mez, Dr. Ashok and Supriya from Ortho TV for taking it through to India, and David Penford from Clockwork Medical for the same thing in UK. Thank Professor Ebnezar and Dr. Amarnath for moderating fantastically. I think we just finished 15-20 minutes later than scheduled. That's great timing. And last but not the least, I thank all the delegates who have joined this meeting from via the Ortho TV. So thank you very much. Have a good day. Anybody wants to do final words, Mez and Evert, feel free.
No, just thank you to everybody. Fantastic.
Thank you and welcome. We'll be waiting for you for the Bristol Hip Arthroplasty course. Please come.
See you all at BHAC. Yeah, that's right.
Absolutely. Good night, all.
Thank you very much. Good night.
Thank you. Have a nice weekend.
Thank you.
Enjoy the match.
Good night. Good night.
Bye.
Bye.